Our team at Ohio State, I was at the Eye and Ear Institute with Dr. Dunca. We were looking at the time course post-operatively of cochlear function through electrocochleography recordings, so after you get that cochlear implant. So the goal of our study was to monitor how residual cochlear function evolves over time after cochlear implantation, and we used those ECoG tools, which I'll talk about soon, to see if we can gather meaningful information about cochlear health. Um, Basically, we did it during a standard clinical visit without needing an op room setting, so that was pretty nice. So just to give a little background, electrocochleography measures acoustically evoked potentials from the cochlear nerve and can be used intraoperatively most commonly to check the nerve as the insert is going into the cochlea, but can also be used postoperatively, kind of as a non-invasive way to check the implant, the cochlea, and the surrounding structures to still see if you have residual hearing. So there are several types of recordings that we can do. First is frequency sweep, which evaluates response values at specific frequencies. So you stimulate it at 250 hertz and see how much of a response you get from the nerve. Secondly is the electrode sweep. So basically, we run the whole electrode, measuring responses along each electrode in the implant, 1 from 22, so going all the way from the base to the apex. And then finally, we had amplitude growth. Basically, you're stimulating the nerve, and then you're looking at the response amplitude and seeing if it increases with increasing stimulus. So as it gets louder, are they having an appropriate response to that change? And we do that at each frequency. So in this study, we used the ECoG software. We used two different companies, one of the Cochlear corporations, one by Advanced Bionics. The platforms looked a little different, but at the end of the day, you get the same exact information. We did this by inserting an earphone on the same side as their cochlear implant, and then you basically hook up a magnet that kind of looks like the same disc of a cochlear implant, and then it collects the data from there. And we use this to look at responses across a wide range of frequencies and compare the ECoG data to each patient's audiometric thresholds and monosyllabic word scores. And then in terms of statistics, we use one-way ANOVA. So we recorded these ECoG recordings from 41 patients whose ages range from 30 to 89 years, so huge range of people, with an average of 66.7 years of age. And then the amount of time between their implant was also pretty variable, so it ranged anywhere from 1 month to 60 months or 5 years. Of these patients, we had a statistician from UNC who only deals with like ECoG responses and deemed that 13 patients actually had significant responses to all these stimuli, which was about 31%. And then breaking it down even further, 10 of the patients that had significant responses were from Cochlear, and then 3 were from Advanced Bionic. So then we divided these patients into 2 groups, those who had recordings taken within the first 12 months of their implantation, and then those who had recordings after 12 months, so after a year. Interestingly, the group that we recorded within the first year had an average of 12.1 maximal responses, while those recorded after a year had an average of 19.2 responses. So this finding was very interesting because it shows that people that actually had their implant longer had more significant responses, and some of those people had their implant for 4 to 5 years. Next, we looked at how age impacted the presence or absence of responses. We found that in participants under 50 years old, about 40% had no significant responses, so 60% had significant responses. And then in the 50 to 59 group, it rose slightly to 50%, and then as we're trekking along, 60 to 69% had 58% of no response whatsoever. But then interestingly, when we jumped to 70 to 79-year-olds, it jumped all the way to 80% with no responses. So only 20% were significant responses from the different ECoG studies. And then once we got to 80 to 89-year-olds, there was actually no significant responses whatsoever. And basically our ANOVA tests showed that this trend was significant, and as you increase by a decade, the proportion of patients showing no significant cochlear responses or residual hearing increase with age. So to summarize, we found that significant cochlear responses can still be recorded years after implantation. So it's good to know that people can sometimes keep their residual hearing of what they had initially. Older patients are more likely to show no measurable responses. And the most important part is that this only took 15 minutes. I would basically just go grab the patient after they had their clinic visit, take them into the room where we had the setup, and it was super feasible to get done within a clinic visit. And Cochlear Corporation and Advanced Bionics both had pretty user-friendly platforms that we were able to make it accessible for clinicians to gather this detailed data about residual cochlear function after implantation. And ultimately, this kind of information is helping us better understand which patients are achieving their most advantageous outcomes after surgery. Thank you.
Okay, and they go right arrow go back. All right. All right. Good morning. Thank you for having me. My name is Tanner Jeffries. I'm a second-year medical student at Campbell University. Today I'll be presenting on a project that I did with Duke's ENT department focused on the post-operative effects of steroids in pediatric tonsillectomies. But first I would like to start off with a question. By show of hands, who here has had a tonsillectomy before? All right, so I personally have never had a tonsillectomy. When I was a kid, I was always jealous of my friends that did because they got to eat ice cream for 2 weeks. Now, I also remember them mentioning they had a wide range of symptoms of either pain or discomfort, and that leads into the focus of our study today. So, a tonsillectomy is a common pediatric surgery with a significant postoperative pain. It's managed with multimodal analgesia, according to the AAOHNS. This includes ibuprofen, acetaminophen, or opioids, which leads into another dilemma that we are facing in healthcare, which is the opioid epidemic. Opioid use in children may at times be risky, especially in children with obstructive sleep apnea. Steroids also have shown mixed results in reducing pain and at times complications in children. And the impact of extended postoperative steroid use on pain and opioid use in pediatrics is not well understood. So here are the objectives of our study. Our key focuses were to evaluate the effectiveness of postoperative steroids on opioid consumption, pain levels and adverse effects from the study, and the feasibility of conducting a larger study. The setup of our study was an unblinded randomized control trial. Participants were randomized based on the day of their surgery. The inclusion criteria was patients between the ages 4 and 21 and those who needed a elective tonsillectomy. The exclusion criteria included recent use of steroids, immunocompromised patients, or patients who underwent concurrent painful procedures. The selection of the groups was based on the day of their surgery. So odd days, they were placed into the steroid group, and the even days, they were part of the control group. All groups received acetaminophen, ibuprofen, and oxycodone, and the steroid group received dexamethasone postoperatively. So here is a layout of the study. We enrolled our patients into the study, and then depending on what day they had their surgery, they were placed into the two groups. And then afterwards, our patients kept a diary of their pain levels and their adverse effects. And then after 2 weeks, we had a series of check-ins with the patients where we would obtain those pain levels, opioid consumption, and those adverse effects. All right, so in our study, we had a total of 24 participants. We had 16 participants that were in the steroid group, and we had 8 participants that were in the control group. And from this chart, you can see a breakdown of the demographics. From our study, there was a large difference in the opioid consumption between the two groups. For about 11.5 doses for the steroid group and 18.4 doses for the control group. The pain levels were similar between the two groups, and the differences of the opioid consumption were not statistically significant. Throughout the study, there were no serious adverse effects, such as reoperation or readmission, but 75% of the participants in each group reported at least one adverse effect, such as nausea, insomnia, or bleeding. The big takeaways from this study is this was the first study of using post-operative steroids in a pediatric tonsillectomy study. There was a large difference between the consumption of opioids between the two groups, and there were no serious adverse effects. Some of the challenges of the study included a small sample size. We initially had a goal of 58, but we only were able to get 24. This was due to funding, but also the COVID-19 pandemic. There was not a lot of elective procedures taking place during the pandemic. The diary writing also was at times burdensome to the families, and also we did lose a couple medication bottles and some incomplete surveys. In conclusion, we believe that this study shows a lot of promise. We believe that with a larger sample size, we could see a statistically significant difference between the postoperative use of steroids and pediatric tonsillectomies. Our future plans are to publish the results of this study in the White Journal and apply for a grant to be able to perform a larger study and improve our recruitment and data collection techniques and evaluate the impacts of the study on the patients. Thank you for having me.
Good morning. My name is Melissa. I'm a fourth-year medical student rising at the West Virginia School of Osteopathic Medicine, and I have the privilege today of discussing a comparison of full and partial opioid agonist therapy in the postoperative period. I have no disclosures to report, and I did want to take a moment to thank my mentors and the faculty at WVU for their help with this project. As you can see here, this is a data chart from the CDC. We're currently in the wake of the third rise of opioid intoxication and overdose, largely due to synthetic opioids such as fentanyl that are being acquired by patients without prescriptions from physicians. So we'll start today by discussing some trends and statistics in the opioid epidemic before discussing some more pertinent information for surgeons, specifically in the field of otolaryngology. The origins of opioid use disorder vary according to the American Medical Association, but for almost half of patients who go on to develop an addiction to heroin, their substance use disorder actually begins with a prescription that they receive from a physician. Furthermore, that data shows that between 3 and about 20% of patients who are prescribed a prescription opioid will go on to develop an addiction to them. So it's really important as surgeons and some of the highest, actually the second highest opioid prescribers, that we're good stewards of opioid use and we do the best that we can to mitigate the risk of patients in developing a substance use disorder. 10% of opioid naive patients who are prescribed an opioid in the post-operative period actually endorse continued use of opioids 1 year post-operatively. And this is regardless of whether or not that surgery is short and relatively less painful than some of the other ones that we see. In addition, we tend to overestimate the amount of opioids that our patients are going to need to consume. And surveys show that most patients don't use all of the opioids that they're given in a prescription. Furthermore, very few actually appropriately dispose of them. And this is important because surveys additionally show that nearly half of opioids that are diverted and misused actually come from prescriptions that were taken from other patients. This is not to say, however, that we shouldn't use opioids. It's important to appropriately control pain for our patients, and effective analgesia promotes outcomes that are better. Patients are less likely to have pneumonia, they're breathing more fully, they're less likely to have DVTs if they're up and they're mobile more quickly after surgery. And in addition, we know for a fact that there are numerous elective otolaryngologic procedures that produce significant pain in patients and warrant opioid therapies. In addition, patients who are prescribed regular courses of opioids, such as buprenorphine or methadone, are actually at an increased risk of relapse, overdose, and death if we discontinue those opioids in the perioperative period. For this reason, it's increasingly common to see providers continue the use of buprenorphine in the perioperative period. Some will even use that buprenorphine to control pain. And there's a 2018 SAMHSA guideline that aligns with this perspective as well. You can see here, this is actually a recent Academy study during one of their clinical guidelines looking at the pain that we can expect from numerous ENT procedures in adults. You'll notice here that tonsillectomy up at the top, and most, if not all, of these other surgeries have at least mild to moderate pain, with tonsillectomy producing severe pain in a number of adults. Anything above that moderate to severe category is considered as potentially warranting some amount of opioid use by the Academy. In this same paper, they produced several clinical practice guidelines. These included observing multiple opportunities for research. First, that would be finding an intervention that can reduce the risk of opioid use disorder for patients who are having surgery. And secondly, identifying specific combinations of medications that we can use to balance pain control, risks, and cost. In addition, they made a formal recommendation stating that clinicians should inquire about a month after surgery as to whether or not their patients were satisfied with their pain control, whether or not they utilized all of their medications, and if any extra medication had been appropriately discarded. This leads me to my next point, which is our attempt at WVU to try and mitigate some of these risks and address those goals posted by the Academy. I think it's important, firstly, to understand the way that opioids work, since this is kind of what led us to design our studies. As we all know, opioids work on the central CNS receptors, mu, kappa, and delta. It's these mu receptors in the CNS that are predominantly responsible for euphoria and analgesia. Typically, when we think about pain control in the postoperative setting, we're using full opioid agonists. An additional form of a full opioid agonist is methadone. This is something we use for medication-assisted treatment. It helps because it's a long-acting synthetic opioid, and it can reduce withdrawal symptoms as well as cravings for patients with substance use disorder. In addition, I'll briefly mention opioid antagonists. This will become pertinent in a moment. These include naloxone or Narcan, which we can use rapidly in the event of an opioid intoxication or toxicity, and this helps to reduce respiratory depression. Naltrexone is sometimes combined in the form of Suboxone with a partial opioid agonist, and it helps to block euphoric effects when it's used for maintenance treatment for patients with opioid use disorder. Partial opioid agonists are the topic of focus for this study. This would be buprenorphine, sometimes known as Subutex, Butrans. It's a partial opioid agonist that is typically used for medication-assisted treatment. Interestingly, it's also FDA approved for the treatment of both acute and chronic pain, though we see it used much less commonly for this indication. It has a longer half-life than some of our full agonists. It also has a higher affinity to opioid receptors, and this is the reason that it can sometimes precipitate withdrawal symptoms in patients who are opioid sensitized. In addition, it has varied formulations. It's absorbed transmucosally. These include buccal films and sublingual films, which in the field of otolaryngology can be beneficial to take advantage of for patients with dysphagia or odynophagia. Again, it can induce precipitated withdrawal, so it's important to keep this in mind for patients who may have already been sensitized to opioids. Common adverse effects are similar to those we see in full agonists, things like nausea, constipation, and occasionally sedation. There are several studies looking at the postoperative use of buprenorphine. Most of these are in general surgery or orthopedic surgery. Very few are actually done in the United States. And I was pressed to find a single one looking at ENT procedures specifically. In fact, I did not find one. In general, they reached the same consensus, though, for our colleagues in general surgery and orthopedic surgery, and that is that buprenorphine has been found to be superior to both morphine and fentanyl, and that this was consistent among those studies. Some of the touted benefits included lower pain scores, predominantly in the perioperative period, briefly after surgery, by a visual analog scale, and that was assessed by blinded nurses in both studies. In addition, for patients who were pretreated with buprenorphine as well as morphine, it took twice as long for patients in that buprenorphine category to require breakthrough pain and begin to report pain symptoms. In addition, adverse effects such as nausea, vomiting, and sedation are consistently lower among patients who utilize buprenorphine, and they have reduced intake of additional breakthrough medications such as acetaminophen or NSAIDs that are used for breakthrough pain. Of note, I will mention that 2 studies did find buprenorphine not to be superior to a full opioid agonist, but did recognize that it was effective and comparable in its efficacy. This brings me to my final point, which is a study that I'm currently working to create with the folks over at WVU. We're in the very initial sort of preparatory stages of beginning this pilot study, and we're seeking to address those academy guidelines, specifically finding an opioid that we can use when we need it, that reduces and mitigates the risk of opioid use disorder, while also being cost-effective, and specifically addressing that guideline, looking at patient consumption of analgesics. At this point in time, we're looking at a single institution, randomized controlled trial, looking at patients who are undergoing either elective septoplasty or elective tonsillectomy, which were among those painful procedures listed by the Academy. They would then be randomized to receive either their surgeon's standard analgesic regimen, which is hydrocodone with breakthrough acetaminophen, or a regimen consisting of buprenorphine and acetaminophen. An additional arm of this study would be looking pre- and post-intervention at patients' considerations and perceptions regarding the use of buprenorphine, the opioid use epidemic, and medication-assisted treatment in general. In addition to assessing the utility of buprenorphine, we hope to see if patients might have reduced stigma as a result of using it themselves. And you can see here we've created a pain diary that we intend to use that looks at both their adherence to the opioids as well as any adverse effects they may experience and further comments for their surgical team. These are my references. And I welcome any questions at this time. Yes. It does not, especially after that MAID Act that was recently released. It does not. Methadone sometimes can, but buprenorphine any licensed physician can prescribe. You're welcome. Any other questions? Thank you.
All right. So my name's Jake Markovich. I'm a third-year resident at Kettering Health Dayton. I'm just going to be going over carcinoma, expliomorphic adenoma, kind of reviewing a little bit about what that is, and a case report, someone that we took care of in our facility. So carcinoma, expliomorphic adenoma, if anyone's familiar with that, basically, it arises from pleomorphic adenoma, and pleomorphic adenoma is the most common neoplasm of the major salivary glands. There's a 15 to 25% quoted risk of malignant transformation to carcinoma, expliomorphic adenoma, if a patient is untreated. And there's a little bit of variance in how that's reported in the literature, but essentially, the malignant component of carcinoma, expliomorphic adenoma can be a number of different things histologically. Most commonly, it's adenocarcinoma, but can be anything from adenoid cystic to mucoep or other salivary duct carcinomas. There's not really an established treatment guideline for a patient that presents with carcinoma, expliomorphic adenoma, but in literature, patients will often receive any sort of combination of chemoradiation, surgical excision, or surgery with adjuvant radiation. And the median survival over 5 years is overall pretty poor at 61.9%. As far as our case goes, so this was a 56-year-old gentleman who didn't really have any relevant past medical history. He came into the ER with like an expansile right-sided neck mass that had been slowly growing over the last 20 years or so. He didn't have any really associated symptoms other than he had this large neck mass on the right side. No trouble breathing, no real trouble eating and drinking, other than the problem for him that it was starting to kind of become unsightly and really obvious and noticeable. He got a CT scan, which demonstrated a pretty large mass that was solid and cystic, exophytic and arising from the right submandibular gland, or appeared to at least, and was 18.7 centimeters in its greatest dimension. He had a biopsy at that point in time, which was suspicious for malignancy, but they couldn't comment any further on what they thought it was exactly. And surgical excision was planned, but he essentially was lost to follow-up before he was able to undergo his resection. About a year after that initial presentation, he represented due to increasing discomfort with this mass kind of just slowly growing. And then, as you can kind of see there, the mass did grow a little bit in size over a year, with its greatest dimension being now almost 22 centimeters, and still, thought to originate from the right submandibular gland. So this is his preoperative CT scans. On your right side is it's an axial cut of a CT scan of the neck with contrast, and essentially demonstrating the tumor appearing to originate from the right submandibular gland, extension into the parapharyngeal space, and then medialization of the great vessels. But overall, just a pretty large, impressive tumor. So the management plan for this patient, he underwent staged excision and reconstruction, mainly to confirm final pathology and make sure that we knew what we were dealing with him. He underwent a large right-sided tumor excision of the neck with skin, and level 1 through 4 neck dissections. And then frozen pathology was concerning for a tumor of salivary origin, which is not terribly surprising based on what we saw preoperatively. And then it ended up coming back as a 22 centimeter pleomorphic adenoma with myeloepithelial and salivary duct carcinoma. And it didn't involve any sort of skin or lymph nodes. And then basically he stayed in the hospital and was able to undergo reconstruction the following week with just pec flap and skin graft to cover the ablation site. So this is the perioperative images of the patient. You can see that he had this pretty large expansile neck mass on the right side, and he was kind of walking around with that for a very long time, just until the point where it got too uncomfortable for him to kind of deal with. And then on your right side is the post-operative images from day 9. And he was healing well at that point in time without any issues post-operatively. And that's just a pec flap with a skin graft covering it over top. So some discussion about this case and carcinoma expiomorphic adenoma. So carcinoma expiomorphic adenoma is basically very rare. It's typically very aggressive and has a poor prognosis. And it essentially, originates from pleomorphic adenoma. So like I mentioned earlier, there's that risk of malignant transformation in patients that have pleomorphic adenoma that are untreated. And that can be, it was quoted, there's one paper that I was reading that was 1.5% in the first 5 years and up to almost 10% over 15 years, the patient is to go untreated. And that's pretty important if you're going to be taking care of patients that have a pleomorphic adenoma to be able to counsel them appropriately about what the risk would be as far as worrying about something crazy like carcinoma expiomorphic adenoma. Most commonly, it's identified in the parotid gland because that's where we think of pleomorphic adenomas arising from. So this patient obviously had the tumor arising from the submandibular gland, so he was a pretty unique presentation from that standpoint. And then, in this case too, it was also important to kind of consider the complex nature of the tumor when you have a tumor that big, not necessarily knowing exactly what the pathology is either. The ablation and reconstructive plans can be pretty complex in planning. So it's important to consider, what all of your options might be, whether or not, this patient would have needed a free flap or something like that as well. And then essentially, this patient unfortunately had several trips to the ER prior to his initial establishment with us, where he had this very obvious, visibly obvious neck mass that nobody really did anything. They kind of essentially said follow up with ENT, and there was no real attempt to kind of contact us and get us involved. So this had been going on for a very long time. So it's important to kind of counsel, all practitioners, not just an ENT, to identify a neck mass, and especially when it's very obvious, and get the appropriate team members involved in treatment. And that just kind of ties into the future implications for this case presentation. Was basically encourage all providers to be able to identify a neck mass and just know who to call essentially when you need some help with a neck mass. And then also there could be some predictive studies that look at patients that are at risk of being lost to follow-up, because this gentleman was lost to follow-up for a whole year, and his tumor grow. Luckily for him, it didn't have too severe of a change in what his outcome was going to be, but he did eventually go on to get chemoradiation following his surgery once he kind of recovered from everything. So he was pretty lucky from that standpoint. Those are my references. Does anybody have any questions? Great. Thank you.
So my name is Drew. Thanks for coming. Drew Phillips from Dayton Kettering Program. So what I'd like to talk about today is another tool in the toolbox to help with resident education, to help with future resident education, to help with students education, and potentially attending and future practitioner education. So as we find, there are a lot of surgical training challenges that we encounter on a daily basis. We traditionally rely on a didactic training to learn our surgical steps early on, either in the student phase or in the resident phase, followed by real-time feedback regarding surgical technique. Following each procedure, we're looking for post-surgical feedback, but it's more based on what we remember from the case, what our attending remembered that we did from the case. Sometimes that real-time feedback isn't as robust as we would prefer, depending on the case, the attending, the day, and that can be a pitfall in knowing whether you are doing things correctly or if there's things that you could improve upon. A conversation that was started within our program a couple years ago is that we look at high-profile athletes who, or even down to high school football level, are reviewing game tape and trying to get themselves better. So we started to think, why can't we do that? So there is a value in beginning to review your own surgical game tape, and a lot of different avenues, as I'll talk about here shortly, to facilitate reviewing your own surgical game tape, both by yourself, with other peers, and people who have a little more experience above you. In your junior resident years, it does provide a way to give you some visual reinforcement of basic surgical steps, your basic technique, and comparing and contrasting with the attending. You think of a beginning of FES, if you're doing the right side and the left, and then the attending does the left side maybe, but you have video of all of it. Now you can sit down and look and say, oh, well, he or she made that step way faster because they did this and transitioned to this. In your senior resident years, can facilitate a much stronger OR efficiency, just speeding up your case and not having kind of dead time moves that you're using. Mastering your craft, it does provide a forever database for yourself of a lot of these surgical cases that, now looking at practicing in a couple months, I'll be able to go back to and take a look at maybe before a challenging case. And it's a great didactic material on from a resident level. Utilization, we started with our recording our cochlear implants and our sinus surgeries, but really anything that facilitates a recording device will allow you to, if you can at least, record it, you can study it. So sinus surgeries, anything in that nature, your transsphenoid approaches, anything in the ear world, cochlear implants, stapes, we do quite a bit of endoscopic ear, so it helps out with that. But quite a few microscopes do allow video recording and have a USB drive as long as they have a internal hard drive. And then even looking at our drug-induced sleep endoscopies, important to do because to get approved, you have to have so many submitted to Medicare. So you should start recording them anyway. And direct laryngoscopies and all the procedures that go with that. So the technical setup, not too bad. So in the most rudimentary fashion, you are able to just carry a large capacity jump drive and, prior to cases, make sure that you can get plugged into it, that everything's turned on, and you should be able to record your video. More advanced, there are several companies that are out there who provide recording devices that hook to your tower and basically record and automatically upload to a cloud database for you and files it for you, which is nice. We do talk about HIPAA compliance with this. Obviously, you don't want anything that has any patient identifying information on the video, especially if you plan on using this for any further surgical training distribution. So how do we integrate this? So I think the first part is ensuring that the resident who is recording this is providing self-review. This can be in the phase of just editing the video. You can speed it up for yourself to watch, or maybe you're really just trying to go to that one difficult portion to review why it was difficult and how you got through it. The second part is in our group didactic review. This is how we're using it, especially in temporal bone lab, where, it's a good way to ensure that our junior residents are up to speed with surgical anatomy, surgical steps, complications. So you can almost sit and have them narrate your own, senior level residence video. And then it facilitates a pretty good conversation when you can actually have a physical video to watch and review, both with attendings, residents, and students. You know, unfortunately, it does provide good material for M&Ms as well. That way, you have an actual visual representation of if there could be a complication. That way, everybody's on the same page and can have a rightful conversation about what occurred. And like I said earlier, it does build a treasure trove of surgical material for your residency program to use for future didactic studies. So common challenges that we have ran into with this early on, they seem pretty menial, but when all these things don't occur or do occur, you're not going to get your video recorded. Forgetting your jump drive, you're not going to be able to record. Not setting it up early in the day, so you're not getting to your OR early enough. Forgetting to hit the record button because you just started the case, and then you get about halfway through and go, oh, I forgot to hit the record button. Technical difficulties, running out of space, OR staff deleting your case before you get to upload it to your jump drive, and not having time to actually sit down and edit your video, which is time consuming. So where do we go with this? So we've began setting up microphones with some of our preceptor attendings at Temporal Bone Lab. That way, now not only are we watching our pre-edited video or raw video, if that's part of the conversation, but now we are recording our conversation along with that video to even add more didactic material to that treasure trove of information. So now, not only do we have a video of surgery to review, but now real-time feedback from that surgery. Again, talking about surgical anatomy, complications. So we just kind of keep adding some layers to this onion of each surgical video that we record to make it a better didactic material. The other thing that we talk about is now, once we start putting stuff like that together, is there an avenue for sharing outside of just our residency or the person who recorded the video? So there are already, the websites out there who allow you to review surgical video from other residents. So that's something that we've started reaching out and actually submitting video with. And then the other opportunities that we talk about are this idea of surgical coaching, which is kind of a up-and-coming idea, but I think it lends itself well to the technology that we have now to be able to record and edit these videos much quicker, but to where even beyond, if there's a certain subset of surgery that you're trying to improve upon or increase your OR efficiency, that you could submit certain videos, probably at a cost, for somebody to review and give you very, tough, constructive criticism, but only to improve yourself even out in regular practice. So with that, thank you very much. Does anybody have any questions?
There's still some of that in me. All right. Good morning. We are going to get started bright and early. I know that there'll be more people trickling in because I know this crew. So I am Dr. Lindsay Madden. I'm a laryngologist at Wake Forest Voice and Swallowing Center, and it's my pleasure to introduce Dr. Ashley O'Rourke, who is a fantastic human and amazing clinician. She is a professor of otolaryngology at the Medical University of South Carolina, where she's also the director of the Trammell Voice and Swallowing Center and holds an endowed chair position. She's held many roles nationally and internationally, and she has graciously agreed to be our laryngology keynote. She flew in, and she's heading to an international meeting tomorrow. So thank you, Dr. O'Rourke.
Well, thank you for inviting me. My good friend Lindsay Madden and colleague, really love the opportunity to come and speak about different things today. Although we have a small group today, hopefully these will be the folks that I might put a little seed in your mind to start doing this. And so that's my hope today, because sometimes dysphagia isn't a huge draw, but hopefully it will be enticing to you to say why we actually need to make it a bigger draw. And then, of course, there are some disclosures that you can see online as well, with some companies that manufacture high-resolution pharyngeal manometry equipment. So if I talk about that, that's my disclosure. So what we're going to do today is just kind of understand the trends in dysphagia evaluation. Like, what are we billing? I'll show you some of the treatment billing codes that we can be billing. But that's like the dry portion. So handouts are available, correct, Lindsay? Yeah, so your handouts are available. So just for the list of those, I'm not going to go through the whole list. And then we'll talk about some questions or discussion that you might have. I do have a big disclaimer. This is my opinion and advice only. Of course, it's based in years of dysphagia practice. I actually was a speech-language pathologist who practiced in dysphagia before going to medical school. So this is based on 30 years of experience of dysphagia evaluation and management, but please talk to your coders, because I don't want you to be like, oh, well, Dr. O'Rourke said, Ashley told me I could bill this. Please don't do that. It's not going to hold up in court for you. All right, so first let's, before we say what we can bill, what are we building? So this is a paper. I have a QR code in a slide or two that you can download and look at this paper. But what are we billing? So my former fellow and I looked back and said, how prevalent is it now for us to be doing this? Dysphagia is important. We all know that. Etiology is multifactorial, has significant consequences. But the main point is that there is specialty involvement. It's multidisciplinary care. So it's otolaryngology, gastroenterology, internal medicine, general surgery. And we can't really relegate this to just the speech-language pathologist and say, okay, that's yours, or the gastroenterologist, this dysphagia is yours. Otolaryngologists are uniquely equipped to evaluate dysphagia. And this is, and I'll try to make that argument for you. The goal of this particular study was to characterize the specialty level variation in dysphagia billing. And our hypothesis was that otolaryngologists and gastroenterologists would perform the majority of dysphagia-related evaluations. So a priori, that's what we went in with, thinking that there'd be higher procedural volumes per performing provider among otolaryngologists. We source these data from the Medicare and Medicaid services, physician and other practitioners database. It's a retrospective cross-sectional analysis, and it focused on the specialties that we just discussed. We did look at dysphagia evaluation-related CPT codes. So this is also later on when we see that list, some of those dysphagia codes that are being billed: manometry impedance studies, pH impedance studies, flexible endoscopic evaluation of swallowing, or FEES, T&E, transnasal esophagoscopy, esophograms, and then modified barium swallow. The codes below that you see under esophagram and you see under modified barium swallow, those are the reading codes that a physician can bill. Those are not, especially for the code here for modified barium swallow, that is not the code that the SLP bills. That's the code that an otolaryngologist or a radiologist can bill. And we'll talk a little bit about how to do that in your practice at the end. The statistical analysis was descriptive statistics and then a one-way ANOVA. And what we did was we looked at the percent of practicing physicians that were billing these procedures, looking at the number of providers performing greater than 10 procedures annually. So that's a little asterisk here. The Medicare and Medicaid databases or data sets only collect data for more than 10 providers that are doing these certain CPT codes. So if you're going back and looking at these databases, just remember that. And the reason for that is anonymity. If you've performed fewer than 10 procedures, then it may be able to be identifiable in some way. So that's the caveat, is these are only providers, the percentage I'm going to show you, that are performing more than 10. But those are higher volume, I think we would all argue. And then we also looked at the number of procedures per provider, taking the total number of procedures per specialty annually, dividing it by the number of providers performing in that specialty. The results were is that across all specialties, only a very small proportion of practicing providers are performing procedural testing for dysphagia. And the majority included procedures that are billed by fewer than 10 otolaryngologists annually. So the majority of the procedures that we're doing to diagnose dysphagia in the United States are being performed by fewer than 10 otolaryngologists. So that should surprise you, because it surprised us, because there are about 700 laryngologists. Right? There's 10,000 otolaryngologists. And so it just shocked me that it was such a low number. This is the QR code that you can get to this full paper. So if you want to see some of these data. The FEES testing was the most frequently performed procedure by otolaryngologists. So there were a mean of 50 providers or 49 providers per year. That's 0.51% of practicing otolaryngologists. So even though we thought, okay, this would be the major one that we would do because we have laryngoscopy is one of our top procedures that we all learn to do. You just feed somebody something, this would be higher. But if you look at it, there's only 50 laryngologists out of all the otolaryngologists. Even if you look at laryngology might be the more specific, that it was still pretty low. And I would argue that general otolaryngologists would be well equipped to do this as well as a screening examination. T&E, only a small number of providers across all fields were doing T&E. It was an average of only 750 procedures, which is not a lot when we think of how many upper endoscopies are completed. 15 otolaryngologists, about 0.16% of the specialty performed this, so less than FEES, but still just about 36 procedures a year annually. And only between 0 and 2 gastroenterologists performing this procedure. So much more they're performing endoscopy via EGD, not transnasal esophagoscopy, because those are very distinct codes, so we can see that. Manometry procedures that are looked at esophageal manometry and or pharyngeal manometry, there were a good number of those procedures that were billed, but again, it's only 0.04% of otolaryngologists. That's less than 4 providers average. With only averaging about 25 of these exams annually. So if you have a voice and swallowing center and you're evaluating swallowing, manometry really isn't going to be something that's a big part of most practices, but it's one of the most integral examinations we have for pharyngoesophageal swallowing. So again, that's pretty interesting. More gastroenterologists perform this than otolaryngologists. The interesting thing was that general surgeons performed a higher number of procedures than otolaryngologists. The general surgeons. Probably this is because these are being used in preoperative examinations for things like Nissen funduplication or other lower esophageal sphincter wraps or instrumentation. And so therefore got surgeons that are likely doing this in their practice. But I would argue that if we're doing other procedures that are addressing swallowing, cricopharyngeal myotomy, other things that we should be also performing these type of examinations as well. 24-hour pH testing, we put it in to be complete, but it's not something that really is germane to dysphagia as much as to a workup, an evaluation for preoperative workup for lower esophageal sphincter procedures or surgical correction of reflux or to evaluate laryngopharyngeal symptoms. But it it is dysphagia related. There's 38 otolaryngologists performing this procedure annually, and that's interesting because it's more than we're performing manometry, a small number of general surgeons. I wonder if this number here, we can't really tell the difference sometimes between it, but I wonder if this number here also includes oropharyngeal pH testing, which is like the ResTech device, because you'll see with our limitations, sometimes we can't tell the difference between that pH testing. Fluoroscopy results, there are 6, we'll round up because there's not half of a person, so we'll say 6 otolaryngologists, 0.06%, that are billing modified barium swallows as a reading fee. So the rest, this is not how many modified barium swallows maybe that person ordered, but they're how many that person actually is billing as the reading provider. This is increasing, and I wonder if the data is going to increase in this, as many laryngologists around the country now have integrated voice and swallowing centers where they are acting as the radiologist in a modified barium swallow. We, for the past 13 or 14 years, have done our own modified barium swallows in-house. You do have to be credentialed to do this through your university, or through your institution or practice. So you need those credentials, and then you need to look at your state and go to their state guidelines and make sure that you're following the fluoroscopic state guidelines. And they vary wildly by state to state. For example, the state of California requires you to actually have a licensure for this that goes through formal licensure process to become certified to be able to do fluoroscopy. Whereas in the state of South Carolina, the requirement is that there is a licensed provider within the room. So you can be an MD, DO, PA, or APP, or a nurse practitioner. And that's all the requirement is from the state of South Carolina. Now, there is a little bit more scrutiny in that in your institution does require, if you apply for those credentials, to show that you do have the training to be able to do that. So like in our institution, you have to go through ALAR courses. So the lowest dose of radiation, you have to prove radiation safety courses, as well as prove that you have a subspecialty in dysphagia and the training for that. So it is a larger hoop than just the state level that says you just have to be a licensed provider. But it's not a very onerous thing to do if you wanted to put this into your practice, and it's done with a radiology tech and a speech pathologist. It's not something that that is too onerous to do. There's limitation to this study. The analysis was limited to Medicare Part B, which are all outpatient claims, so we did not look at the inpatient. That is more likely to be your radiologist anyways. I'm reading a lot of the modified barium swallows, but also a lot of the other examinations are not done as emergency procedures in the hospital, like a manometry or a pH test. We do occasionally have those, but it's pretty rare. It does reflect the patterns, though, of primarily older adults because of the Medicare, although the Medicaid is in there. Also, there's a potential underestimation of procedure volumes because it's billing practices, not the studies ordered by those given specialties. So, for example, as an otolaryngologist, you may order a lot of modified barium swallows, but maybe not read those in the way that you're dropping the reading fee. However, one of my little soapboxes is that if we're going to intervene and make clinical decisions in this area, we should be able to read our radiographic examinations. Those of you who do sinus surgery would never dream of going to the operating room and not reviewing your own CT scan, not looking at it and making a judgment on your own. You might look at that radiologist read, you may collaborate with them, but it is something that you're going to feel comfortable being able to look and assess that anatomy. And that is the same argument for swallow studies, is that looking at and evaluating those images and being able to make a clinical judgment, maybe you might consult the speech pathologist or do that as a team, but it is something that we should be more comfortable with. And then the last is the potential ambiguities in provider specialty coding. So in some instances, like internal medicine might be radiology in some situations, so that there is a little overlap. Just like I talked about, those general surgeons may actually be foregut surgeons. So overall, a very small fraction of otolaryngologists are performing dysphagia-related procedures. It's because I think there's a disconnect between otolaryngologists' unique training and then our actual practice patterns. And so we lack that, we feel that we lack that training or expertise. And so we farm this out then to other specialties such as speech language pathology, gastroenterology, instead of partnering with them or being more integrated into the decision making. And then additionally, office-based procedures, we have a vast ability to perform these diagnostic and therapeutic procedures in the office that maybe some other specialties don't. And so I think that if we can educate ourselves a little bit more, we already have that ground level of knowledge, that if we can just push that a little bit further, we'd be more comfortable doing those other things like fees, especially, or manometry. I mean, we stick things down people's noses every day. It's not that difficult to place catheters. So I think it's just getting over that little speed bump and really expanding your practice and that knowledge. And what we really need to do is that dysphagia is an ACGME core competency for gastroenterology fellowship, but it's not for otolaryngology residency. So, GI fellowship is kind of what I akin to a little bit of our residency, because remember, they go through internal medicine, then do their gastroenterology fellowship for 3 years. And, for us, we don't have a core competency in dysphagia for otolaryngology. So again, I think that we're doing ourselves a disservice, because where in your institution, if somebody has dysphagia, who do they refer those patients to? All right, they're going to refer them to gastroenterology for sure, but also otolaryngology as well, especially oropharyngeal, and your gastroenterologists are going to ask for your help on that. All right, so future directions, let's do educational enhancements, incorporate dysphagia into the competencies for otolaryngology. We just need to be better integrated into dysphagia care and really use those multidisciplinary dysphagia teams. And then just address those potential procedural reimbursement and equipment access barriers. And just increase that otolaryngology participation. So to that, in that vein, let's talk a little bit about what you can bill, and then we can have some real frank conversations about whether it's worth it, and RVU and payment reimbursement and some of those things. And of course, again, I'll say my caveat that this is my opinion and just based on my experience. So what are those common diagnostic billing codes? The fees, a 92612 is the endoscopic examination. Like if I go into a room and I put down a scope, and then I have my nurse give that patient food, and then I make an evaluation of their safety of swallow, efficiency of swallow, aspiration or penetration, we do follow a very specific template. And so it's not just giving them anything willy-nilly, but you do need to follow some kind of a standard practice. But that's a fees evaluation, and it has very important implications for you. And you can bill that 92612. If you're only interpreting it and writing a report, so say your speech language pathologist does it, or you have an APP that does it, then you can do the reading fee for the interpretation report if you review that and then make a decision. But it's great for the patient that comes in and you want to make an evaluation or assessment of their safety. You come in, you think they're aspirating, and you need some kind of an evaluation pretty quick to be like, do I need to get them a modified barium swallow this week? Do I need to tell them to thicken their liquids? Do I need to, or is this something that can wait? Is it something that maybe I can get a modified in a month or so? Is it something that I can have the speech pathologist triage first and maybe do a clinical evaluation? Fees will really help you with that, because you're going to see gross aspiration or penetration or other things that are going to clue you in as to the safety of the swallow. That's then going to inform your decision on your temporal management of that. The others are just things that you can kind of see, and like I said, it's in your handout, but feel free to take a picture of this too. This is the reading code that you bill that you saw in our study, or a modified barium swallow if you are going to read this and this is, you don't have to be in the room unless it's a state law that you are, but this is like afterwards you look through. So what we do in our practice is the fellow or the PA goes downstairs in the morning and does modified barium swallows all morning. We do 8 to 12 a day. And this is 1 day a week. It's not every day of my practice. 1 day a week, we do 8 to 12. They were down there with the speech language pathologist, a radiology tech, and then the fellow or the PA. And I'm running a full clinic upstairs. Then at 3:30, everybody gets together, all the speech pathologists, all of our team, and we sit down and we go over the modifieds together. and it's called our laryngology rounds. That's a small part of our laryngology rounds where then I review all the studies, drop the charge, and so it's nicely integrated into our day. Then we look at all the manometry studies that we've done. Those are done by the PA or the fellow or the SLP. Then we look at the pH impedance studies that are interpreted by our PA, and then reviewed by me, and I drop that reading charge. And then we go through all of our other airway patients or voice patients that are also placed on the list. So in an hour and a half, we kind of just review all of the dysphagia studies that were done for the week, as well as all of our patients that we're following that have special needs. So it's a way you can integrate it into your practice, however it works for you, but it's really plausible to be able to do. And the nice thing is that these are our patients that we're doing this for. We're not taking a lot of outside referrals, and so they're patients that I've already seen in clinic or so-and-so has seen that I'm going to do a myotomy on, that I'm going to address. So it really helps us to develop a plan with that patient and then follow back with them. So it's really comprehensive care. It's very difficult for me when I have somebody who gets an outside examination. I get a report. They didn't follow the same protocol that we follow, even though it might be a fine protocol. It's just not our protocol. And then I don't have the video images. And then I have to make a decision on how to manage that patient. It's just very difficult for me to do that without all that information. So this is a way of streamlining that. Impedance pH monitoring. This is just to say if you want to do manometry and impedance, because they're together, they're in the same catheter, you need to really talk to your coders because they're bundled together. So you may be better off just billing manometry or maybe better off billing impedance. This is also with pH testing too. I found out 2 years into my practice that they were stripping the impedance code because I was billing them together. And impedance has more RVUs and pays more. So for 2 years, they were just stripping the code that was better, sending in the manometry code because they were bundled, and they were like, well, it's not the second code we just take off. So talk to your coders because that's important. And then you see the esophagoscopy codes, and then these are just the other codes that you can also bill when you're doing procedures. One thing that I did want to point out is this is a very interesting thing right here, is that there's really no specific code that directly describes endoscopic CP myotomy. So we were talking about laser myotomies. There actually isn't a code specific to that. There's actually a code for rigid transoral diverticulectomy with or without CP myotomy. So your coder may tell you that this is the best code to bill. Some of us can say, well, there's early Zinker formation, I'm doing the myotomy for that, and bill this other code, but that is a little controversy there, just to point out for those of you who may be doing myotomies. The other thing I wanted to point out is this, Botox into the cricopharyngeal muscle. It is, there's a couple of different ways that you can bill this. You can bill this as a 43192, or you can bill it as an argument that the cricopharyngeus is attached to the larynx, and this is an injection, a laryngeal injection, because you're not doing a full esophagoscopy, you're really doing a hypopharyngealoscopy, whatever that would be. You're really looking at the hypopharynx. And so at our institution, we bill the 31571 after discussion with our coders and our compliance officers. So this was a discussion that we had together, so just so you know. That's a little controversy between these two. Check with your coders for sure. There are a couple, just to finish up, there's a couple of models of billing with SLPs and APPs. This is something that's really, that's asked a lot. Fees, we talked about, you can bill if you do the fees, or you can bill if you're just interpreting the fees. SLPs can co-bill when you're doing these. So if I have we have speech-language pathologists now integrated into our practice where they'll come see patients with us during the day. We may be there together doing the fees. I may bill the fees, the 92612, and they'll bill an evaluation of oropharyngeal swallowing function, so the 92610. They can also then, if I step out of the room and then they go on to do a treatment session, maybe they're going to look at some strategies and use biofeedback with the laryngoscopy to show them things, then they're going to bill a treatment code based on that. So there is a way of integrating this into your practice so that you're both maximizing your billing, and that's not a dirty word or a dirty thing to say. You should get paid for what you do. They should get paid for what they do. You are combining your practices together for the benefit of that patient. And so it's okay to do co-billing when it's within lines of billing practices. In the non-hospital-based practice, the thing about APPs, this is something that some of you probably realize because you have APPs within your practice. If you're in the hospital setting, so if your clinic is considered hospital-based, then you have no problem with billing incident to your PA. So your PA can go see somebody, you go in, say hi, you drop the bill, fine in a hospital setting. In a non-hospital-based setting, that is not okay. That is, I don't want to say fraud, but it's not okay. And so you can bill incident to in certain situations where you use an FF modifier. So let's say the APP goes in. So I have an APP, she's a PA, she runs a full clinic while I'm running a clinic. But there may be a cancer patient that comes in or an airway patient that comes in. It's something beyond her practice. She'll come and grab me and say, hey, can you look at this patient with me? I go in, talk to the patient, we do whatever we need to do. And I drop the bill with an SF modifier that says that she requested a second opinion. So that is fine to do, those situations. What isn't okay these days anymore, which I don't know if it was ever okay, but it was pretty common practice 10 years ago or so, is that your PA would see patients, you'd see patients, and then you'd bill all of their codes. And it wasn't really something that you were involved in, interacting with. That's not okay in the outpatient, non-hospital setting anymore. Talk to your coders. Again, my opinions. Okay. Oh, wow. 0, 0, 0. I finished right on time. Okay, good. All right. Questions, though. Sorry, I should have left time for questions. Maybe I didn't finish right on time. Yes, sir.
So if I have like a new patient who comes in, they're specifically sent for fees. I do the fees. I don't have SLP with me in clinic right now.
Sure.
I do the fees. I do the interpretation. So I can do both those codes, correct?
No. You can either interpret it or you can do it. You can't drop both.
You can't drop both.
Cannot
Now,
drop both.
where does say the patient also has a voice complaint? Can I do a stroke?
You can do a stroboscopy. A 31579, you can. You cannot do a 31575, which is a normal laryngoscopy code. A laryngoscopy code, the laryngoscopy is considered part of fees, so laryngeal function is considered part of the fees examination where you would comment on vocal fold mobility or contractility of the pharynx. So you can't do a 31575, your normal laryngoscopy. But you can do a 79 because that's it's a voice assessment, not a laryngoscopy is. Yep. We do that commonly with folks. Okay, any other questions? Yes, ma'am. Sorry.
And up there for doing a Botox injection in the cricopharyngeus muscle, they're billing it as a chemical myotomy.
I'm sorry, say that again?
They're billing it as a chemical myotomy.
For Botox? Talk to your coders. It's an injection. There are chemodenervation codes, like as you guys know probably, that we use when we do facial Botox or when we do when we're doing SD treatment or laryngeal tremor treatment. Those are chemodenervation codes, but chemical denervation as a myotomy is cutting of the muscle. So if you look at what the CPT code is describing, it's describing something different. But talk to your coders. And I don't have my glasses on, so I'm sorry if I call people different things. Sorry. Thank you. Thank you.
Okay, so up next, we have our panel on cricopharyngeal muscle dysfunction. And I know a lot of people just came in and weren't here for a previous introduction of Dr. Ashley O'Rourke, who is a professor and endowed chair at the Medical University of South Carolina. So we're very excited to have her today. And then new to the lineup is Dr. Dan Fink, who is coming to us from the University of Colorado. He's an associate professor there and division director of laryngology. He spent some time in New Orleans, so if you want to talk to this guy about food, you should catch him at the break. And again, I'm Lindsay Madden. I'm a laryngologist at Wake Forest University Voice and Swallowing Center.
All right, it's me again. How do we want to do this, Lindsay? Do we want to get another microphone and I'll sit? Or do you want me to be here? Okay, all right. All right, it seems so formal to stand up here with that. Okay. All right, so we are going to talk about okay, all right, okay. What time is it? 8:35 or 8:25? Okay, all right. So we're going to talk about all about CP dysfunction, pathophysiology, the diagnosis and treatment. Our goal with this panel is for it to be as interactive as possible. So, 8, 10, okay, thank you. So please feel free to interrupt, raise your hand, just shout out. I'm one of 7 children, so I'm really used to being interrupted and interrupting other people. So please just shout out if you have a question, if something doesn't make sense, or best if you disagree. That would be awesome for you to be like, well, I respectfully disagree, or have another opinion, or have something. So please feel free. We have lovely experts up here, Dr. Fink and Dr. Madden, treat this condition and will give us a wealth of knowledge, but please join in the conversation. Disclosures are the same as before. We're going to talk a little bit about background, just because I think that's important, but what I really want to get is the case discussions. There are too many cases for us to discuss in the time we have. So don't, at the end, when I skip some things, that is on purpose. It is meant to just be filler in case we just don't find anything to talk about together. But also just knowing that maybe other questions come up and maybe there might be a case that people had questions about that might better inform us. So there will be more cases than we can get through, and we'll get to the ones that people want to hear. All right, so a little bit of background. Understanding CP muscle dysfunction and its contribution to pharyngoesophageal dysphagia is very important. It is the failure of the upper esophageal sphincter to relax and open during swallowing. It should really be called cricopharyngeal achalasia, but since the gastroenterologist or the lower esophageal sphincter has commandeered that term, so if you hear achalasia, you automatically think of LES achalasia, so we can't call it cricopharyngeal achalasia because that gets too confusing. So we call it CP dysfunction. The overall incidence of symptomatic CPD in the general population is actually pretty low, but it's a common cause of dysphagia. So there are lots of people running around with the incidental cricopharyngeal bars. In fact, it ranges on video fluoroscopy from about 6 to 15%, and is probably there in approximately 30% of patients over the age of 60. So just because you see a cricopharyngeal impression, bar, hypertrophy, whatever you want to call what you see over on the right-hand side of your screen, just because you see that doesn't necessarily mean that they have CP dysfunction. Then we have to think about their symptoms and overall swallowing function. Just to get this out of the way, the anatomy, it's a striated skeletal muscle. It's the predominant, but not the only component of the upper esophageal sphincter. There are also contributions from the circular esophageal musculature as well as the inferior constrictor muscles. It is a horseshoe-shaped muscle located generally about C5 to C6, and it's tonically contracted at rest. So unless you're swallowing, vomiting, or burping, your cricopharyngeus should be closed, therefore your upper esophageal sphincter should be closed. All right, so Dr. Fink, what is your definition of cricopharyngeal dysfunction?
Oh, you gave me a microphone. That's not good. Not good for you guys. So I think cricopharyngeus muscle dysfunction is anything that does not allow the cricopharyngeus muscle to open, and that causes impairment of bolus flow. So I would add that on the end. If it doesn't impair bolus flow and everything still goes through well, then I would not call it dysfunctional cricopharyngeus muscle.
What do you think, Dr. Madden?
I agree with that. I won't disagree right out of the gate with Dr. Fink.
Do you distinguish between internal and external cricopharyngeal dysfunction? Or do you think cricopharyngeal dysfunction, by saying cricopharyngeal dysfunction, has to be the cricopharyngeus? Like UES, pharyngoesophageal segment, cricopharyngeal dysfunction.
When I think about cricopharyngeal dysfunction, I'm just thinking about the muscle. If I'm thinking about other issues with pharyngeal contractility and things like that, I think that's more, it's sort of a different entity that kind of all plays a part.
Right. So that's kind of what the controversy, there a couple of years ago at COSM, a group of us got together for dinner and argued for like 2 hours. It got pretty heated after a couple of bottles of wine about what cricopharyngeal dysfunction means, because I think CP dysfunction should be purist, that it's a CP muscle, but then the UES, there's all these other kinds of things. So I think when we start to talk a little bit more, we'll kind of see these issues come up. So complete relaxation of the UBS is achieved via complex interaction of the bolus pushing through the UBS, hyolaryngeal mechanics, so the larynx moving upwards and forward to kind of distract that area, as well as neural inhibition. And this is kind of what most people think of first, is that tonic inhibition, so that the muscle does open and relax. It's the failure of CP relaxation that increases the risk of post-swallow pharyngeal residue and therefore penetration and aspiration. So that's what makes it unsafe. CPD may present as solid food dysphagia, that's kind of the most common, choking, coughing with liquids, globus sensation, sensation of food sticking, or regurgitation, but not like 10 minutes after the meal, 15, 20 minutes after the meal. It's more like an immediate thing. Okay, so Dr. Madden, what types of pathology do you commonly see in this segment?
I mean, the big thing is pharyngeal diverticula. I think it's one of the most common things that we see and treat.
What about you, Dr. Fink?
I think we see a lot of older folks who have lost good opening of their cricopharyngeal segment. We also see a fair amount of patients with neurologic pathology causing it.
So neurologic inhibition is decreased, but then also more, what do you think? Why do older people get CP dysfunction? Like why over 60% of folks have some kind of a cricopharyngeal bar or something like that on their esophagus? What do you think? Why?
I think it's a combination of two things. So I think part of it is that CP muscle needs to be, and all those tissues need to be elastic, and like all of our other tissues, as I am learning more and more every year, get less elastic. The CP muscle is going to get stiffer, it's going to get scarred. And then also people, I think, lose some of their neurologic signaling that allows for good relaxation. And then, as you were saying, I think the other thing that we or at least I have to be careful of, is the hyolaryngeal opening. So the CP muscle relaxing is important, but also the larynx pulling forward is important. And when the larynx is not pulling forward as well, then the CP is not going to open as well.
Yeah, and I think also esophageal dysfunction with aging and is this sort of a compensatory mechanism too.
Okay, so you alluded to this a little bit, Dr. Madden, about where we have diverticula can form in the hypopharyngeal or upper esophageal region. And just to look at our anatomy one more time, this is in the handout. I think this is kind of the best one. I don't know who named these. Like, this is Killian's dehiscence. This is where a Zinker diverticulum forms. So I'm like, why isn't this Zinker's dehiscence? I don't know why. Because where a Killian-Jamieson diverticula forms is actually in Killian-Jamieson's area. So that makes sense to me. But so this is just to show that if you have a diverticula that's above the cricopharyngeus, it's going to be a Zinker diverticulum. If it's below and lateral, then it's going to be your Killian-Jamieson diverticula. And if it's under the cricopharyngeus in Lemire's dehiscence, again named appropriately, I think this is Lemire's diverticulum. So it's just that if any of you out there are residents and going to go through boards, don't let that trip you up when they ask you where a Zinker's diverticula actually emanates from. It's Killian's dehiscence.
And I think it's important here to mention too, if you're not doing your own fluoroscopy, like if it's done in radiology, which we're not fortunate enough to have the nice fluoro suite, but the radiologists call everything a Zinker, and the management of these different types of diverticula is really different. So look at your own fluoroscopy.
Yeah, tell us a little bit about that. What's the difference in the management between a Zinker diverticula and an Killian-Jamieson diverticula?
I think for me, Zinker's is mostly all endoscopic management, and if you have a KJ, you have to do an open procedure, I would say.
Right. Dr. Fink, why do you have to do an open procedure?
So two reasons. One is because KJs are very challenging to expose, and I would say one learning point is if you ever have a Zinker's that you thought was going to be straightforward and you cannot expose it endoscopically, go back and look at your fluoro. It may be a KJ that you missed. My partner, when I was down here, I remember, I think the only mistake I ever saw him make, and he was cussing mad at himself, was a KJ. That was in years. He's a really good doctor. Anyways. But the other reason is because if you go endoscopically on a KJ, you have the potential of hitting the recurrent laryngeal nerve, and so you've got to be very careful about that.
Yes, exactly. The recurrent laryngeal nerve tends to run on the underside of the Killian-Jamison diverticula. There is actually a publication out there about endoscopic management of KJs, but I would say you get lucky. In my hands, it's an open procedure. Open procedures are pretty quick and fairly safe, so there is a different management for these, which is, again, goes back to the previous talk about us being involved in looking at our own imaging. I had a radiologist years ago that I called and I said, I think this is a Killian-Jamison diverticula, not a Zinker's. And he's like, well, what's that? I was like, oh my gosh, this is the person
Had
who
that
read.
same experience.
Yes, this is the person who read this. And so they also are not being educated in this area. As well as maybe we could be doing a better job of that. So we need to educate ourselves so we can educate other folks as well. All right, so what are some of the most common causes of CP dysfunction that you see in your practice, Dr. Fink?
The common causes of CP dysfunction, say the most common is still kind of just age-related change, but also see, I've got a family of OPMD patients. I don't know if we're going to go down that road.
Yeah.
And some stroke patients who we see. And then our skull-based team does create some vagus nerve injuries every once in a while, which will help my children go to college.
So OPMD, so muscular dystrophy or oculopharyngeal muscular dystrophy. Mm-hmm. And what about you, Dr. Madden?
I'd say similar.
Same thing, anything different that crops up with you?
I mean, I think some people, again, is it dysfunction? You know, the argument if a patient has pretty bad esophageal dysmotilities, is it actually dysfunction, or is it because the compensatory issue with the CPM?
All right, so tightening of the cricopharyngeus over time is a compensatory mechanism to keep gastroesophageal or esophagogastric reflux out of the pharynx. So there are causes of cricopharyngeal dysfunction. I think it's helpful to kind of break these up into neurologic versus inflammatory. So we have stroke, Parkinson's disease, vagal neuropathy, as you were saying before, could be idiopathic or could be related to disease states, or it could be iatrogenic. And then you have idiopathic spasm. I've had a few patients with that over the years, and we don't know why. They respond really well to Botox. And then you have myopathic, so you have your dermatomyositis, inclusion body myositis. I have a big cohort of patients that we see with this. They do very well with myotomy. Then you have gastroesophageal reflux, radiation fibrosis of the muscle, not necessarily a web or a stricture, but radiation fibrosis of the muscle itself. And then age-related, like you were talking about, that's a huge cohort. Esophageal dysmotility, as you were talking about, Dr. Madden, as well. And then we have those folks that we just don't know. Your 56-year-old that comes in that has nothing else except for this, it's kind of difficult to know. All right. So consider factors that contribute to decreased pharyngoesophageal opening but are not primary CP dysfunction. So this is kind of alluding to the question I asked you earlier about intrinsic versus extrinsic. So when we're talking about cricopharyngeal dysfunction, we're kind of talking about the cricopharyngeal muscle. But then there are all these other things that could be cohabitating with this or causing more issues like radiation strictures, cervical osteophytes, which happen to be most common at C5 and C6. And that's because when you lean forward, you place a lot of stress on the C5, C6 vertebra. It's actually like a little phrase for this. It's called text neck. And because your head weighs about 10 pounds, so when you're looking up, all that weight's distributed down, just like if you're holding a 10-pound weight here versus a 10-pound weight here, there's a lot more stress on my joint when it's out here, and so I think we're all going to have text neck, and there's going to be a lot of ACDF surgeons that are going to be very wealthy. Exactly.
I saw so many
as
people
I'm looking down
in the room.
And whenever I read modifies, I look at the neck. I'm like, that's such a pretty neck. I'm like, I wonder what my neck looks like. I'm too scared to look. It's got the huge osteophytes or something. And then oropharyngeal dysphagia, and this is what you were talking about, Dr. Fink, where pharyngeal contractility, like the hyolaryngeal mechanics of if you've had a stroke and you can't pull that larynx up and forward, you're going to have issues, but also the pharyngeal contractility, like you were saying, Dr. Madden, where you can't push it. I have an SLP colleague who she likes to say, look, we can open the door, but you're going to have to walk through it. So we have people with terrible pharyngeal contractility. I do cricopharyngeal work on them, or UES, PES, pharyngoesophageal segment work in all kinds of forms. but we need to tell them this is not going to fix your swallowing problem. It may help, but the reason we're doing this is XYZ, but you still have this pharyngeal contractility bolus flow issue that's going to keep going. All right. Questions before we get into cases? Anybody have anything else to add to that or dying to ask a question? All right. So case 1. This is a 72-year-old female. She's had a 7-year history of dysphagia. It's been worsening slowly over the past 2 years. What questions do you ask this kind of a patient, and what else do you want to know about her? Dr. Madden.
Yeah, sure. I think, anytime a patient comes in with symptoms of dysphagia, the first thing I kind of want to think about are those alarm symptoms. Weight loss, diet modifications, have they had an aspiration pneumonia, they have a history of smoking, pain, throat pain, anything like that. I think the alarm symptoms are kind of critical to ask as a first step.
Anything else to add, Dr. Fink?
I always want to know dysphagia to what? So dysphagia to pills, dysphagia to solids, dysphagia to liquids. Is it only bread? Sometimes it turns out it's actually globus, and it's like, oh, I don't have trouble swallowing any food or drink, but I feel that lump there when I swallow. And you're like, oh, okay, I'm going to cancel that modified order now.
It's always cornbread. They always have dysphagia to cornbread in North Carolina.
Rice, for some reason.
You get
It's
rice,
like, I
I
don't
get
know why
cornbread.
rice. Rice is a common thing that people complain about. We're going to get to it in a little bit, maybe, but in case we don't, Dr. Madden, you mentioned pain. How does your workup change when it's odynophagia versus dysphagia?
I mean, I'm always going to scope these people, right? Even if they're coming in with just dysphagia complaints, I'm going to look at their larynx too. So I think, that's a big important part. If it's not part of your workup, you want to take a look at the larynx, make sure you're really honing in on, are they, they have neck mass, do they have any symptoms there? And I'm really probably, if their larynx looks okay, I'm also thinking maybe esophagoscopy to look at the mucosal lining of the esophagus, look for anything concerning there.
Okay, gotcha. Yeah, odynophagia is one of those red flag symptoms that most people agree that esophagoscopy is warranted with a negative laryngoscopy. Pill ulcerations and, esophagitis as well as cancer. That's a big factor. Okay, so this person had solid food dysphagia and pill dysphagia. Symptoms were alleviated by liquid swallows. They occasionally regurgitated undigested food during or immediately after a meal. Often felt that she had to swallow multiple times on each bolus, had no weight loss, dysphonia, odynophagia, or pulmonary symptoms, so none of those red flag symptoms, had a history of heartburn that was adequately controlled on once daily PPI inhibitor therapy. So she just had the GERD. That was about all of her past medical history. All right, this is her fees. So this is laryngoscopy, but then you'll see that she'll start to take some bolus. But what, Dr. Fink, just talk to us what we're seeing here as we're looking. Like, what are some of your initial judgments?
I believe that's a larynx.
Check. Okay, there's a swallow.
So we're looking at a laryngoscopy. We're seeing healthy mucosa, no masses or lesions or strictures or anything like that. We're seeing full abduction and adduction of the vocal folds, which do look to my eye a little bit atrophic. We are seeing some pooling of saliva and secretions. It looked like it was more, now it's in the right piriform. I thought it was in the left before. But it is clearing through with swallows. And pharyngeal squeeze, and it's hard without sound to know when she's doing what action. But it looks like tongue-based retraction isn't terrible, and pharyngeal squeeze is also not terrible.
Okay.
But no frank, huge deficits to explain her dysphagia symptoms.
Sure. So I can't control the video from up here, but I think you made a really good point about the pharyngeal, like we see it disappear. But watch what happens when she's eating pudding. Okay.
Hello.
So the protocol here that was used were thin liquid sips, then sequential thin. So I'm trying to fill a diverticulum if there is one there. And so we feed these people pretty fast. This was in real time. So look at how fast we fed her these kinds of things. Once we saw that she was able to clear everything through the pharynx, but it's only when it gets to that UES that really we see it pop back up and rear its ugly head. So this is one of those typical characteristic things that you're going to kind of see. All right, so how often do you use fees in your practice with patients?
Yeah. Yeah, we do a lot of fees. So, I see patients in an interdisciplinary clinic, and if a patient has a dysphagia complaint, whether or not they're coming with fluoroscopy studies, pre-visit, they're already getting a fees. So I think it gives us a lot of information quickly. Like you said before, we can look at that pharyngeal residue. We can really trial, bolus trials to like pack up that diverticulum, and it's given, us a good vocal fold motion assessment, which I want before I'm going to do work on the CP.
Yeah. Yep. If you saw that fees, that was your patient, Dr. Fink, what's your next step? I can't remember if there's next one, so I'll skip. But what's the next step for you?
So for me, so the next step, I'm getting imaging. Then I'm usually getting a modified barium swallow study with esophageal follow through.
Okay, modified barium esophageal follow through. Is that what you would order?
If I have a fees and I'm pretty happy with it, I'll go ahead and just get an esophagram because that gives us a little bit more information, I think, about the LES. So
Gotcha. And there's no wrong answer there. Those are both the answers. What do you think may be the possible diagnosis? What are possibilities? I mean, it's very obvious, but we might as well state it.
Cricopharyngeus muscle dysfunction.
CPD, yeah. But what else? Besides CPD?
Zanker.
A Zanker. Or
Or
Killian-Jameson.
pharyngeal
Or-
diverticula.
Yeah, pharyngeal diverticula. It's funny, there's a paper out, it's the Pouch Collective, that says that you can have diverticula without CP dysfunction. So that's interesting to wrap your head around, right? I think Killian-Jameson diverticula don't always have CPD. So CPD does not equal diverticula. They often coexist together, but it's not the same thing. They're not the same anatomically.
And the Pouch Collective is a big group of us that are involved with work out of the University of Cincinnati with Rebecca Howell. So, it's a nice body of literature about all things CP. So I'd encourage you to take a look at that if you want to treat these problems.
Yeah. I can't remember what POUCH stands for, but it's like prospective outcome. They made it fit that cricohypertrophy, I don't know. So I think that you guys touched on the one that most people would do. It's video fluoroscopy. There are some others that are also used. We touched kind of on esophagoscopy, but also high-resolution manometry. If we think that this is an issue like a compensatory issue, then we might do pH impedance testing or reflux testing, especially we might also go on with manometry for esophagus. EMG is actually used to assess CP muscle dysfunction, but it's really relegated to research because it's quite invasive, as well as the interpretation can be a little difficult. But I stick that on there just so we know. All right. Do you agree or disagree with these statements, and why? Whoever wants to take it first. So besides fluoroscopy, the preoperative workup for CPD is controversial. At the center of the controversy is whether CP myotomy may result in worsening reflux. So is fluoroscopy alone all we need? You're good to go. Operate away. Botox away. Dr. Madden.
Again, I don't know, I'm going to have to pick one side, right? I would say fluoroscopy alone is probably not enough. If the patient's not had esophageal mucosal evaluation, solid food dysphagia, I still want to look at the esophagus, and the lining.
What kind of esophageal work did you say?
Oh, like a mucosal evaluation, like a T&E, or if they've had an esophagus. But I may be doing that at the same time that I'm going to go treat the CP.
Good point. So esophagoscopy is one of the, I'm not going to say essential, but I am going to say essential, but let's just say that. There might be cases where it's not, but that would be one of the more essential things that you would add on to fluoroscopy, but you might do it when you go to do, you've already decided what your treatment is, but you're also going to make sure there's no concomitant issues lower down. Yeah. Gotcha. Okay.
I just want to see that,
Yeah.
look for esophagitis.
Yeah, lots of folks do that, sure.
So,
Dr. Fink?
yeah, so I would not jump to doing a myotomy, but for me, if this person has CP dysfunction, usually what I'm doing is a transnasal esophagoscopy with dilation. So I do the esophagoscopy and dilate in the same procedure. And obviously, if I see something on the esophagoscopy that's a huge smoking gun, I might abort the dilation. But yeah, I would be a little nervous about jumping right to a myotomy without either seeing it and then seeing how they do with the dilation. Because sometimes if you dilate them, you might be surprised and make them worse or something like that, and then you didn't do anything permanent, at least, like you do with a myotomy where you kind of can't take it back.
Gotcha. So you tend to, there's a step between saying myotomy. The controversy is like what the next step might be, but also esophagoscopy is important to you as well. And I think that brings up those good points, those like kind of don't miss kind of things. And then of course it's patient specific. So if there's someone who I'm sure comes in with symptoms that guide you down a different path, you're doing something else. All right, this is this person's, this woman's esophagram. You see it starting from the left to the right. And this is what you see. And we talked about how to decide modified barium swallow versus esophagram. Do you find that, Dr. Fink, you said modified barium swallow, and Dr. Madden, you said esophagram. Talk to me about frame rates. This sounds really esoteric, but it is actually really important. Frame rates, video fluoroscopy, esophagram versus modified barium swallow, and how that might affect your treatment.
Something that's very unhelpful. Sometimes I'll get outside imaging and it'll be like 5 frames per second. So
We get
basically,
four.
We get 4. Yeah, it's like just still images. That is so unhelpful. And I think, I like 30 frames per second, which gives you that you're not going to miss a little aspiration that may happen, gives you beautiful imaging of what's happening with the CP. But I think at a bare minimum, the radiologists really try to push back on that 30 frames per second. They're like, too much radiation. I'm not that worried about that. But 15 at the bare minimum, I think you should ask your radiology team for.
What about you, Dr. Fink? You have any issues with frame rate?
Yes, we've had the same issues as Lindsay was just saying, and I completely agree with everything she just said. And sometimes it does take some very frank discussions with your radiologist about missing pathology to try to get them onto your side. And we've mostly won that battle, but I'm not going to say we've won it entirely. It depends who's down there.
Yeah. And we have trouble with the esophageal follow-through on a modified barium swallow. It can be so variable what type of imaging we get, if it's like the radiology resident that's like in the wrong field of view. So that's why I lean towards the esophagram.
Right. So most modified barium swallows nowadays with speech pathologists following standard protocols are going to be 30 frames per second, which is considered continuous. A few may do 15, but 30 is the standard for modified barium swallows, whereas esophagram's about 4 to 5 frames per second. We get 4 frames. Every once in a while, you get 2 frames per second. And this is the reason why. When you swallow oropharyngeal, it's about a second that it takes for you to do that in a normal individual. When you swallow in the esophagus, it's 10 to 14 seconds is considered to be normal. So if you're only going to do 4 frames per second in the esophagus, well, that's fine because you got a lot of time. That bolus is moving much slower. But if you're in the oropharynx, the bolus is moving so fast that those shots were the only shots that I got of the pharynx. So that was the only time that we ever saw a CP issue, was this right here. And so it's just difficult. I didn't even have one that was after the bolus had gone through to see what residue was. So we have made a deal with our radiologists that they would do the continuous only on the lateral portion, not on the AP portion. We didn't win that, but on the lateral portion, at least they would do continuous fluoroscopy for at least that one screening swallow, because that's all they do, 1 AP, 1 lateral, the rest of it is esophageal, and then they can go to the lower frame rates for the rest of it. And that has really helped, but then you could change your radiologist, and the next radiologist does it different. So it can be a battle. But please just have that in the back of your mind, and then start looking at your imaging that you're getting and being like, oh yeah, this is what's going on. This is why I might be missing things, particularly not maybe even just CP dysfunction, but webs. Webs can be missed really easily this way and can be quite symptomatic, and you just never even saw it. And then you'll go in to do your esophagoscopy, you'll put in like a DITO, stretch that hypopharynx real open, and then it becomes really obvious as you've stretched that open over there. Okay, so next step, we talked kind of about my dilation maybe. Okay, so CPD treatment can include swallowing therapy, believe it or not, dilation. It can be Botox injection, rigid myotomy, flexible endoscopic myotomy, open CP myotomy or diverticulectomy, or CP-POM or Z-POM, which are or more flexible per oral endoscopic myotomy. And I think the chosen treatment a lot of times depends on the cause and the severity of the symptoms. So this is an individual who's swallowing. This is not the same person that we just saw. This is not her. But this is a person who is not swallowing anymore. And you'll see what starts to happen is we get significant regurgitation. They end up with a 7 centimeter. This is all from the pouch. This is all regurgitation. So this is not, they're not swallowing, this is coming up. So this person probably is somebody at significant risk that you're gonna maybe jump farther, right? A totally different person than the person that we're seeing today. So I just wanna kind of point out, not that we're gonna talk about this person necessarily, but we're talking about this one patient. It doesn't mean that this is how we're going to follow every single person that goes through. Okay, so like you, dilation, I did, dilation was completed. And I think this is in the click sequence. Yes, okay. Dilation was completed. This can be accomplished by bougie or balloon dilation, safe, minimal complications, can be done in the OR, the office. What the literature has shown are their shorter term results with need for repeat dilation being common, but safe and minimal complications. All right, so let's talk a little bit about dilation, and then we kind of address that. So for dilation, Dr. Madden, what's your preferred method? OR, office, and balloon type, and then Dr. Fink will ask you the same question too.
So we have a procedure suite, so our patients get propofol sedation for these. The only people I office dilate would not be this person, cancer patients, radiated, typically who I do. It's mostly convenience, I think, just because we have the procedure suite. And I prefer, double balloon dilation to the UES. We don't have the infinity balloon, which is the new kidney-shaped balloon, because my hospital just doesn't want to buy them yet, so even though 2 balloons are more expensive. So I think getting that double balloon kidney bean shaped dilation is important. That's my
Gotcha. What about you? What's your preferred, Dr. Fink? This is the infinity balloon that she alluded to. It's a double balloon.
Do you guys know what the infinity balloon is or why we use it?
Talk about that a little bit, Dr.
Anybody
Fink.
showing- it's a beautiful picture of it right there. Good timing. Good
I think
stage
the vendors
presence.
are here. They're balloon. I saw the balloons out there. I think the vendor, they have those balloons here today, I
So,
think.
basically, your bougies or your standard dilation balloons are cylindrical in shape, and the upper esophageal sphincter is not. It is more of an infinity shape. So I think Dr. Belafsky, or maybe Dr. Postma, I don't want to say the wrong thing.
In ovine
But a
model.
couple of those folks noticed that, so they started doing double balloons. So they would put 2 cylindrical balloons together, or a balloon and a bougie, to mimic the infinity shape of the upper esophageal sphincter and get a more anatomically correct dilation to get the full AP and lateral dilation. And then finally, after years of doing 2 balloons together, somebody decided to put the peanut butter and jelly in one can together and create an infinity-shaped balloon. And so now we have these infinity-shaped balloons, which, at least in theory, give you a more anatomically correct dilation of the upper esophageal sphincter. And so I don't know of any comparative data that definitively shows improved outcomes, but it's a very interesting idea. I've started using them. I think in my hands they work about like functionally about the same as a dilation balloon, but I've only done a handful, so personally I can't attest to how much better or not better patients get. But other than that, very similar to Madden. I'll do dilations for radiated patients in the office. But if they're not radiated, I tried it once and it didn't go well. Other than that, I like doing mostly T&E dilations, and I do them with just some light sedation. And I usually just have the anesthesiologist give like a gentle squirt of propofol right before the balloon goes up, and it's quick and easy.
Are there certain populations that you think are better or would be more recommended to use the single balloon, just the regular controlled radial expansion balloon, versus the infinity balloon? Or I shouldn't say infinity because that's actually the double balloon. We'll call it the double balloon here, this type here. So double versus single barrel. What patient might you use caution, or just everybody? Use everybody because the CP is round. I mean the CP is kidney shaped, not round.
Radiated patients, I think we want to be a little bit more careful. I'm I'm pretty aggressive in a non-radiated patient with, because I really want to get to the little webs and the CPM, but I think you still just have to be a little careful with the radiated patient.
Yeah. What about you, Dr. Fink?
Yeah, I would agree. Also, if they're really narrowed or if there's a giant osteophyte pushing on posteriorly, then I'm a chicken. I will own that and attest to that, and I'm good with that. I know myself, but then I will usually at least start with a single balloon and tell them, like, I don't want to tear you, and if we get partial improvement, then I will say I'm sorry and bring you back and do a more aggressive dilation.
And I use 2 balloons actually, again, not this. So sometimes if I'm a little worried, I'll inflate the first balloon and then see how things go. And then I'm like, oh, okay, I'll be fine. I don't get mucosal tearing or anything like that. And then I'll just throw another balloon down. Or a Maloney sometimes in a balloon.
Yeah. Yeah, a Maloney in a single balloon, I think, is less expensive than the double balloons, too. So that's another thing. Laryngectomy patients are another patient population that I only use single lumen because their cricopharyngeal region is not round anymore. So that's the other.
I don't ever use 2 in a laryngectomy patient.
Yeah, that's the other population. When do you stop, Dr. Fink? When do you stop dilating? How big? There are 3 levels of the double balloon. They go from 23, 32 to 36 millimeters. Multiply that times 3, and that's your French. So think about that. That's over 100 French. They're now coming out with a 26 millimeters, so 23, 26, 32, 36 millimeters. But when do you stop? Like, who do you judge on their size, of how tall they are, how much they weigh? When do you stop dilating?
Well, first of all, anytime there's a mucosal tear, immediately stop. Anytime I see blood, immediately stop. That's enough for that day, and then we're moving on. But in general, if I'm doing double balloon, I'm starting with the 23 size, and I'm kind of gently inflating it. You can see it kind of unfurls and locks into the UES. And I'll start, it goes up. You're supposed to inflate it to 5 atmospheres. I'll usually start at 4 atmospheres, and then we'll kind of give the balloon a tug and see if it's really snug or if it kind of still wiggles. I know that's not scientific. I appreciate that. But I'm from Florida, so deal with it. If it's snug there, we'll stop there, and if it's still got a little wiggle to it, then we'll go up to 5 atmospheres. And then usually that's enough for day 1. And honestly, if you've got a 23 balloon in there, it's fully inflated, and they're still having a lot of trouble, I would really kind of rethink, is the CP the main problem, or are there other things we need to be thinking about?
Got it. Anything else to add, Dr. Madden?
I think I like to see a little mucosal tearing. I mean, I'm like, oh, good, there's some blood. So I like to have a little mucosal tearing. I think if you don't see any of that, you're probably not being aggressive enough with your dilation.
Yeah, especially if there's a web. If there's a web, you need disruption, so you should go to a little mucosal. But you should stop at that point. Don't keep going.
Exactly. I don't add another balloon.
But occasionally, like you, Dr. Fink, we'll have a person that doesn't have a web, and there's just CP dysfunction, hypertrophy, and I'll go all the way up, and they still don't, but I'm not bringing out more and more and more. We get to what we think might be therapeutic for them. All right. We are going to skip to the second case. This is fine. We don't need to see this. And what we're going to do is we're going to get to the second one. Sorry. Okay. 5 minutes. I'm going to go over that in the RCPD anyway. So case number 2. This is a 54-year-old male. I'm going to make this a little bit shorter for you guys, but basically he had a stroke. He had a G-tube placed. He's in PO because he had aspiration-related pneumonia. He has dysarthria. He has every risk factor that you can think about for stroke. So if you think of one, he has it. Quit smoking about 10 years ago at this time. So do you approach this patient differently than the first case? Why or why not? Dr. Madden.
I think I do. With neuro people, I think I'm a little bit less apt to do the whole, esophageal mucosal evaluation, things like that. And I'm thinking I want to intervene, even though this is a high stroke risk, intervene to that cricopharyngeus muscle a little earlier, and maybe not just with the dilation, but maybe think about adding Botox, which I don't typically use in the patient like we had in case 1.
Dr. Fink, do you use Botox in like the patient that we just talked about? You said dilation in CP, case 1, but you didn't see Botox. So are there certain people that you use Botox for and certain patients that you don't?
So yeah, for neuro patients, I'm much more likely to use Botox, and then stick around later for the RCPD talk, and we'll talk about Botox more. This is my lead-in for you, trying to sell.
That's, the neurologic patients.
Yeah,
right.
but for me, so I do a lot of my dilations awake with a flexible scope, and I think it's very hard to safely inject Botox and stay away from the PCA muscles with that approach. So if I'm putting Botox in there, then I'm usually putting them to sleep, which obviously adds a little bit. So now we have general anesthesia. I'm doing a rigid scope, which arguably causes a little more soreness or pain afterwards. So it adds a little bit to it, and obviously cost of the Botox.
Yep, exactly. Okay, this is what this patient looks like. This is not this patient, but this is what he looks
Artist
like.
rendering.
He has left facial nerve palsy, ptosis of the left eye, nystagmus, palatal myoclonic movements, dysphonic, dysarthric, and gait was ataxic. So does anybody recognize this syndrome? May recognize that syndrome? MRI of the brain revealed a left lateral medullary infarct. And so this is Wallenberg syndrome. And so Wallenberg syndrome also, just because of the nucleus ambiguous, cranial nerve 9 and 10 are affected, can also lead not only to CP dysfunction from a neurologic standpoint, but also can lead to to dysmotility in the esophagus. So just so you know, because the esophageal pattern generators also are within the nucleus ambiguous for the esophagus too, and the pharynx as well. So pharynx too. So now we got to start thinking about pharyngeal drive issues, not just due to that. So neurologic causes of CP dysfunction are often overlooked, and they could have a bunch of different causes. Okay, so what's your next step? We said Botox, right? So we're going to do Botox. This is this individual here. This is what his next step was. Sorry, we didn't go straight to treatment. We did a modified Barron swallow.
Oh, yeah. Assume we made that assumption.
Assume that we did modified Barron swallow. This is a modified Barron swallow. So this is our next step. I know the case, so that's the problem. So we see here, this is really different from that last person that we saw, right? We're seeing really outflow obstruction there at the cricopharyngeus, but we're seeing a lot of residue here at the pharyngoesophageal segment in that postcricoid region there. Okay, so decreased contractility. So look at the pharynx here. It is not squeezing there. You see really decreased tongue base retraction, decreased hyolaryngeal mechanics, decreased pharyngeal stripping wave, a lot of residue in that postcricoid region. Manometry also showed that he had the same difficulties. So we're going to go to Botox. How much Botox do you use when you do this? In this patient?
In this patient.
In this patient?
Yeah.
How much Botox are you going to use?
30 units, that's my typical.
30 units. What about you, Dr. Fink?
I usually use 50 to 60 units. I would also say that I would not touch this person until they agreed to start working with a speech and swallow therapist, and that would be at least as important as any procedure I do for them. Excellent.
Exactly. So we're going to do Botox. I do 30 units for these folks in 10 aliquots, 10 unit aliquots. So you'll see the cricopharyngeus exposed here in the surgical view, and these are the areas where a lot of people put Botox. What happens if I come up here, Dr. Madden, if my injection is too anterior?
Yeah, I might end up with another vocal fold immobility, and these people a lot of times already have one, so.
Right, so
don't wanna get on the wrong
PCA.
side, yeah.
So into the PCA. What if I get, Dr. Fink, I do my injection, I do it back here. I'm a little submucosal and posterior.
You could, where you're kind of pointing, you could get towards the constrictors and actually cause worsening pharyngeal weakness, which I've done.
Right.
Yes,
Yep.
I'm guilty too. And I tell my residents, I'm
Not
like,
as often
you
as
don't.
Madden. She's done it more, I'm pretty sure.
Yeah, I've read you. Yeah, with residents, I tell them, I'm like, when you stick the needle in, you'll easily slide above and below the CP. So like it feels almost like you'll know when you're in it. It's like a little pop into a rubber band. It's kind of what it feels like. So, but it's easy to slide above or below and get in the wrong spot.
Yeah. Anything else you do to avoid kind of a submucosal? Is there any tricks that you have, Dr. Fink, or anything that you?
So one thing that I think can be very useful is using a telescope, like a 70-degree telescope with your injection needle, so you can actually watch it go in. And it's funny, like, teaching this, the number of residents I've had, like, what do you mean you're going to feel a pop? I'm like, just put the needle in, you're going to feel the pop. I don't know, I don't under... Oh, there it is. Okay, yeah, I got it. I'm in the right spot, Dr. Fink. Like, yeah, okay, good.
Tactile.
And I don't stop anticoagulation for these people for this procedure. I think that's
Good
another
point, because this
clinical
person was
pearl.
on Plavix, so you don't stop anticoagulation. Do you, Dr. Fink, for a Botox injection?
I'm too scared of a stroke. I don't want to have another
Yeah.
stroke. And
Yeah.
I
So
don't,
soon.
And I don't really wait. I'll try to like move forward if I get these people early because I think it makes a big difference.
The other thing that I've learned, I like to put the Dido in, and it's so quick and dirty, but this is a weirdoscope that you're seeing here. And I've learned over the years that if I pen the cricopharyngeus better than you can with a Dido, like really get the esophagoscope or the Benjamin slimline, something like that that helps you to stabilize it. I think my injections, I don't have any data to prove it, but I think you can pin it better so you can pop into it versus just seeing it and letting it be floppy. All right, so we're going to stop here, but except for one point that I wanted to make was that this person did participate in swallowing therapy, just like you said, Dr. Fink. This is not something we are going to cure on our own, but no further Botox injections were needed, and this person progressed to a mechanical soft diet, thin liquids, no PEG, and did well. That actually is shown in the literature that most of the times for these stroke patients that they don't need ongoing Botox like we'll talk about later with our CPD. So it's just something, there are 2 really good studies out there that show this follow-up over many years of time. Okay, thank you.
We'll move on to Dr. Fink's lecture next. Thank you.
Hello, everybody. I'm Dan Fink. I'm a laryngologist at the University of Colorado. I've known Dr. Madden for a good long time. It's really special for me to be here. The first person who taught me to look at airways actually was a DO, was our anesthesiologist who did all of our pediatric airways when I was a resident. And because I'm a moron, I didn't really know what a DO was, and I had to actually ask him at one point, like, how come it says DO and not MD on your badge? And Corey was, as he was very gentle and nice with teaching me about airways, he very nicely and gently taught me about DO, so it feels really cool to be here, so thank you. I'm going to talk to you a little bit about vocal leukoplakia, how I treat it, why I treat it the way I do. As Dr. O'Rourke said, if you guys have questions, concerns, thoughts at any point, raise your hand. Shout out reasonably respectfully. This is New Orleans, so you don't have to be that respectful. You know, hopefully we can all learn something together. Still have nothing to disclose. Haven't signed any contracts in the last 20 minutes. So just to kind of go through the overview and our learning objectives for our talk, we're going to start by talking about preoperative workup. And we all know we have laryngoscopy, but I'm going to try to convince you that using either narrowband imaging and or stroboscopy can really enhance your ability to pre-screen your patients. I'm going to talk about some surgical tricks and buffoonery that I've learned over the years. And finally, we'll get into some voice outcomes as well as malignant transformation rate and recurrence risk that is important to know. So when we say vocal leukoplakia, one thing that I think is always important to kind of go over, especially with trainees, is that it's just a clinical descriptor. It's not a pathologic diagnosis. So we're saying, what are the outcomes for doing this or that with vocal leukoplakia? It's like not that well thought of an argument, in my opinion. So what we're actually seeing is keratin forming on the vocal fold. So the vocal fold should be non-keratinizing squamous epithelium. And when we're seeing keratin forming on the vocal fold, something's gone wrong. That might be just change to non-keratinizing or to keratinizing epithelium. That could be dysplasia with that change. That could be cancer with that change. And also infectious diseases can look an awful lot like leukoplakia, and we'll talk about that as well. When we're treating it, we are kind of trying to balance it because obviously the larynx is the most important organ in the body, and we really want to preserve it and preserve the patient's voice, but we also don't want to have the patient be coming back every 2 weeks because we're not being aggressive enough, or God forbid, let something grow and progress to a malignancy on our watch. So in terms of laryngoscopy and stroboscopy, there's pretty solid data for this. This is not just Fink rambling. But what we have found, what the data has shown pretty conclusively, is that if you're using stroboscopy and you see that a patient has a leukoplakic lesion with intact mucosal waves, the vocal fold is still vibrating well, you can pretty much rule out malignancy, not 100%, but pretty damn close. What the data also tells us is that if you've lost mucosal wave, that can happen for one of a million reasons, and you haven't learned anything except for that it could be real bad. So very sensitive, but not specific. Mucosal wave intact, we're pretty sure that this is not cancer, could still be dysplasia. If mucosal wave is lost, could be anything. Good? Make sense? So just to give you a sense of what that looks like, and I'm sorry it took me a while to get, there we are. So this is a patient who has a leukoplakic lesion of the right vocal fold, and this is somebody I'm not that worried about as being cancerous, and I'll tell them, you know, this could very well be precancerous, and we should address it, but, you know, the odds of this being true malignancy are quite low. This is with a 70-degree rigid exam and a little bit of tongue-based tension, so it took me a second to get his tongue out of his mouth. Sorry about that. Can you guys see that? Appreciate that? Now, this is the corollary. So the first one was Beach Boys' good vibrations. This is not so good. So here we again see, this time, a left vocal fold lesion, and we see that that vocal fold is not vibrating at all. Now, could this be one of many things? Yes. Could it still be dysplasia? Yes. But do I need to counsel this patient quite a bit more on the fact that I'm much more worried about this? Absolutely. And of course, she was a retired ENT. So the other thing that you can use that you may or may not be super familiar with is narrowband imaging. In narrowband imaging, what we're doing is we're using a combination of blue light and green light to highlight the subepithelial and submucosal vasculature. And as we know, bad things make blood vessels grow into them much more so than good things. The GI literature on this is astoundingly good. They use it a lot when they look at Barrett's and things like that. For us, we are using it more. The Europeans, unfortunately for us, are a little bit ahead of us on this, but we're learning more and more about it. And what you'll see is if it looks almost like a papilloma where you see these dotted little spots through your lesion, you need to be alarmed. If you see big branching nasty vessels going in and out of the lesion, you need to be alarmed. And again, got some data to back it up, not just Fink rambling. I'll let you know when I'm getting to my ramblings. But Kraft et al. In this paper in Head and Neck, they looked at 205 patients, and they blinded the reviewers to either look with just white light or white light plus narrowband, and their sensitivity, their ability to rule out badness, went from 79 to 97% using narrowband. The other advantage to narrowband is, as we all know, getting stroboscopy equipment is absurdly expensive. Thank you, University of Colorado. But you may already have narrowband on your imaging system or narrowband-like thing. So like with the Pentec system, I think it's called iScan, it does pretty much the same thing. And again, sadly, I have nothing to disclose. So whichever imaging system works for you. The other head fake is if your patient has been on inhaled corticosteroids, if your patient has been on antibiotics, if your patient's immunosuppressed, you've really got to think about fungal laryngitis. As mimicking leukoplakia, there are a few things in laryngology as embarrassing as getting a path specimen for what you thought was leukoplakia back as candida with no dysplasia or malignancy. It's a big oops. And what I would encourage you to do is if you see a patient where you know you're not sure, where they're on, and most of them are old smokers who are also on Advair for the COPD they also have because they've been smoking forever, I would encourage you to use fluconazole, or pill form of antifungals versus a nystatin rinse or swish and swallow. The reason for that is they basically have to be aspirating the nystatin for it to get good penetration of the vocal folds, and you will get fooled a lot where you will clear out everything in the pharynx. It all looks great, the palate looks great, the piriform sinuses look great, and the vocal fold's still there and you're not sure if it's leukoplakia or not. So I usually do diflucan 100 milligrams for 14 days and see them back in 2 weeks. Nobody's going to have a massive disease progression in 2 weeks, but if you can save a patient a trip to the OR, that's pretty huge, especially when they're older and sicker. Office lasering. Does anybody have access to office laser? Do any office laser besides the two in front? So we do a lot of it in laryngology. I like to use it for benign disease and papillomas. I wish I had you guys on stage so I could ask you. But a word of caution when you're doing it with vocal leukoplakia, if you so choose to do it, is you are going to need to do it more than once, most likely. The other thing that's really important is, again, leukoplakia, clinical descriptor. We don't know how deep this lesion is invading into the vocal fold, right? So there is a chance that we are just laser resurfacing a cancer over and over again as it invades more and more deeply because our laser is only hitting the surface tissue. So for me in my practice, I'm only using office laser if they have intact mucosal wave and no scary narrowband imaging features, but to each their own. And then photodynamic therapy was a really cool idea that didn't really pan out, but basically spray the vocal folds with this chemical, 5-aminolevulonic acid, which is a photosensitizer, hit it with the laser to really try and kill the dysplastic cells more efficiently. It was a really good idea. Doesn't really work that well. Office biopsy is something that if you have channeled scopes and you're able to do it, patients tolerate pretty well in the office. The thing you have to remember with office biopsies is they tend to be very superficial pieces of tissue. And so the specificity is great. If you get an office biopsy and it's cancer, it's cancer. But if you get an office biopsy of a nasty looking lesion and it just comes back as dysplasia or some other thing, you may want to think about taking that patient to the operating room and getting better tissue. And the reason for that is the false negative rate is huge, and the sensitivity is quite low for office biopsies. So for me in my practice, I'm using office biopsies for patients where they're really sick, they're really old, and I would really like to avoid the OR if I can get a good biopsy and get my diagnosis in the office with the knowledge, with having discussed it with the patient, that if this comes back as not cancer, I'm taking you to the operating room. So now we've done all that. It's not antifungals. It's not fungal infection. We tried antifungals. That didn't work. Now we're getting ready to take the patient to the operating room. Again, we don't know how deep this lesion's going into the vocal fold definitively. We have some suggestions based on our stroboscopy and narrowband, but we don't know. So when we're talking to this patient, we're trying to figure out, are we just going to biopsy this lesion, or are we going to remove it or excise it? We want to know how aggressive the patient wants us to be, because we can do transoral laser excisions for even pretty aggressive lesions if the patient so wants. But they might not want that. They might just want us to take biopsies if things are coming out. We need to talk about healing time. So if we're doing especially the more aggressive excisions, their voice is going to be garbage right after, and it's going to take a while to heal. And then one thing that's very humbling about treating precancerous lesions of the vocal folds is the recurrence risk, and you do everything right, and then a year later, there's a lesion right back, and it can be frustrating. Getting into operative technique a little bit, having an array of laryngoscopes at your beck and call is really important. The right laryngoscope for you might not be the right laryngoscope that fits Dr. Madden or Dr. O'Rourke. And then when you're mapping out your lesion, using a 70-degree telescope to look into the ventricle and look into the subglottis, I think is very useful to creating a 3D map in your head as you're going to do your excision. And you can see if you use a little right angle tool, you can actually lift the false fold out of the way to really get a full inspection of that ventricle. Sometimes you'll be surprised about how lateral it goes. False folds can be annoying. You're allowed to zap them. So if the false fold is in the way, you can get rid of some false fold tissue very safely and without a loss of function in any way. The other advantage to doing that is it can make your surveillance a lot easier after the fact when you're in the office trying to look and trying to get all the way into the ventricle to see. So don't be shy about removing a little false fold tissue. Hydrodissection is a really cool tool, I think. So injecting a little bit of saline, I use saline, some people use epi, but I inject saline into the subepithelial space for two reasons. One is, again, as part of my diagnostic protocol, if the lesion lifts with a saline injection, then I'm less concerned that this lesion is deeply invasive. The other reason is I can use the saline to push my lesion into my field of view. So if I inject out laterally, I can actually push the lesion medially. And then obviously, voice outcomes, the saline might act as a little bit of a heat sink if you're using laser and give you a little less collateral damage. Y'all are quiet. Nobody's disagreed verbally, like vigorously with anything yet, but we'll see. We're not done yet. Again, a little data to try to back up what I'm saying. So this group, Peretti et al., a wonderful group, Italian group, they basically used a combination of stroboscopy and saline infusion to try to decide how deep to go when they were doing these excisions of these leukoplakic lesions. And if a patient had normal stroboscopy and the saline infusion lifted the lesion well, they only went under the epithelium and kept the vocal ligament intact. If either one was abnormal, they went under the vocal ligament and did what we call an ELS type 2 resection. We'll get there in a moment. And if the patient had had a previous biopsy, then they felt like they couldn't say what the tissue planes were, so all of those patients got a transmuscular excision. And what they found was it was very rare for them to undertreat patients when they used this protocol. However, they did overtreat 13 patients, most of whom were in that previous biopsy group. So for me in my practice, what I derived from this study is if everything's normal, I'm very gentle from a stroboscopy and saline infusion standpoint. If anyone is abnormal, I'm going to be a little more aggressive. However, I don't follow that previous biopsy guideline because it was wrong a fair amount of the time in their study. A few things on excision technique. In terms of margins, if I'm worried this is cancer, based on strobe, based on narrowband, and the patient's given me permission, I'm going to cut around this lesion with a 1.5 millimeter margin to try and be one and done, one-stop shopping. If everything looks really normal and it's most likely to be some mild dysplasia, I'm not going to take as much tissue. I'm going to use a very narrow margin. A really stupid thing that took me, because again, Florida, a little bit of time to learn was that I have a pattern generating laser that I can make a line however long I want it to be. And if I want to measure a 1 millimeter margin, I can just set my laser line to 1 millimeter and measure that. I know, it's too long. But cool trick, and if anybody's like me, learn that easy way. And then in the setting of especially a previous biopsy where the tissue planes are not so good, I really like to use a transection cut where I cut right through the lesion using a CO2 laser with very good depth control until I see healthy tissue. And that's how I make my decision about how deep to go into the vocal fold. Not my technique, Steiner's technique, but it works really, really well. And if you have an appropriate pulse CO2 laser, you can really go through just a quarter of a millimeter at a time until you see that healthy tissue and then decide how deep you want to go to get your margin. And then finally, especially if there's any trainees in the room, cutting out the posterior aspect first and then the anterior aspect helps for two reasons. Reason number one, blood drips down, right? So if your excision's a little oozy from your first half of the excision, it won't get in your way on the anterior half. The other reason is because as you suspend your patient with your laryngoscope, it'll actually push the interstitial fluid out of the tongue and relax the jaw, so you'll have an easier and less traumatic time getting the anterior exposure once you've been in posterior exposure for a little while. So, helpful hint. Hemostasis, we have to, I know I'm bringing the Colorado here, but you gotta be patient, you gotta meditate, do what you gotta do, but try to avoid cautery until your specimen is out, or preferably at all. The reason for that is your margins are gonna be garbage if you use cautery as you're trying to remove it. It's gonna create a lot of artifact. And the other reason is if you can remove the lesion without cautery, the vocal fold will heal better. So when we talk about lesion excisions and kind of those subligamental, subepithelial excisions, they're graded by the European Laryngologic Society criteria, or ELS. And I just want to give you a couple pictures of kind of what that looks like so you know as you're going. But so an ELS type 1 resection or a subepithelial resection, so here we can see the vocal ligament and some of the superficial lamina propria still intact here on the post-resection. So these patients will obviously heal quite well and have pretty good voice outcomes. I have data to back that up. An ELS type 2 resection, so now we are removing the vocal, oopsies, wrong button. So now we're removing the vocal ligament and we can see the bare vocalis muscle here. In an ELS type 2 resection, this can be very useful, again, if your saline infusion or your stroboscopy or your narrowband, anything where you're worried. If you take that vocal ligament, you're going to have that full basement membrane, right? You're going to usually have a deep margin that is very easy for the pathologist to call. And there's one absurdly small and not appropriately powered study that actually showed, believe it or not, that patients, when we did an ELS type 2 resection, had better voice outcomes than when we did an ELS type 1 resection. And the theory is that it kind of frees the muscle up to vibrate better once you've taken all the vibratory tissue off the top of the vocal fold. Not powered well, hard to say, but I will say that ELS type 2 resections, once they're healed, do have a pretty darn good voice outcome. ELS type 3 resection, so obviously this is kind of getting into more aggressive things, and this is what they were doing again in the Peretti study for anybody who had had a previous biopsy, where you're getting into the muscle of the vocal fold and taking a cuff of muscle with your margin. And usually for leukoplakic lesions, we're not going beyond that. It goes all the way up to 6, and sometimes we make some very big holes, and those usually get patients cancer-free, but don't have the best voice outcomes. In terms of specimen orientation, these are very small specimens, and your pathologist will hate you less. They still will hate you, but they will hate you less if you orient the specimen for them. So the way I was trained to do it, the way I still like to do it, is these urologic cassettes. They're very cheap, they're very easy. Comes with a little cassette, you put a sponge in the bottom, you put your specimen in, put another sponge on the top and lock it into place. Labeling, don't use the surgical skin marker, use a Sharpie. The skin marker wipes off and then nobody can orient it. Ask me how I know. When you're taking your specimen out, another Florida guy thing I learned, is to take the smoke evacuator off of your laryngoscope before you try to remove this tiny little specimen microscopically through there. Otherwise, you're going to be trying to find the specimen somewhere in the suction, and it's embarrassing. And the other thing you can do, and that I will do not infrequently, especially if I'm taking multiple specimens, is I will actually take a picture and label it and send it to pathology with my specimen, so they know exactly where what is coming from. Because especially if you're making a transection cut through this mass, right, one margin's positive, because you cut through it, so it damn well better be positive. In terms of laser versus cold steel for elevation of the lesion, there's kind of good arguments on both sides of that debate if it's superficial. If your lesion is more deep and you're going to have to go through the ligament or to the muscle, I think you're really going to have to use the laser. But it is important to note that there's going to be, in addition to your ablation with your laser, there's going to be a margin around where the pathologist is not going to be able to tell between dysplasia and laser artifact. And that margin is usually about half a millimeter for epithelium, a little less for collagen. And again, avoid that cautery, do your deep breathing, box breathing, 4 in, 4 out. In terms of frozen sections, I don't get them, I don't like them. I find them to be very, very, very inaccurate. Sometimes I get them to make me feel better from the deep margin of a nasty resection, but oncologically I don't think they're all that useful. Excisional biopsy from the deep wound is not as reliable as getting the margin from the tissue, but also can be done. Moving on to postoperative voice outcomes. So when you do an ELS type 1 or 2 resection, so again, that subepithelial or subligamentous resection, and this was studied by Rowe et al., they found that patients had significant improvement both in their patient-perceived voice handicap index, so that's something the patient fills out, how much is my voice bugging me, and the Gribus score, so the observer-rated voice, both significantly improved from pre-op with an ELS type 1 or 2 resections. This was kind of surprising to me that ELS type 3 and 4 resections, not significant improvement, but any improvement. So ELS type 4 resection, just to be clear, is removing the entire vocal fold, so it must have been pretty bad voices pre-op. And 5 and 6 we're not even going to get into. But long story short, if you're doing these, as a laryngologist, like anything below the Ranke space feels a little aggressive, ELS type 1 and 2 resections, you're still going to win from a voice perspective in addition to a cancer perspective. Recurrence risk. Recurrence is kind of one of the frustrating things that is just going to happen with these leukoplakic lesions, even with appropriate resections. Overall risk of recurrence, and this is something you should really be thinking about counseling your patients on before, is 16 to 22%. It's not insignificant, and as you might imagine, there's good data to back up that the risk increases with dysplasia severity. And the time to recurrence is 16 months. So this isn't somebody you want to see at 3 months and then be done with. This is somebody you want to do surveillance exams on for a while and make sure they know that the first thing they're going to notice, of course, is a voice change. And if they get a voice change, all of a sudden they need to call you. Malignant transformation risk, this is the big thing that we're trying to avoid. So malignant transformation, depending on the study, 10 to 30% increasing with increasing severity of dysplasia. So 10% for mild dysplasia, 30% for severe, moderate, depending on which study, 20 to 25%. And malignant transformation happens over years. So again, this is somebody you're following for years, kind of like you would a cancer patient. And those are my references. I got 2 minutes for questions or insults or rotten tomatoes or whatever you choose.
For your pictures that you were showing your pre-op, post-op, were you using CO2 laser in those cases?
Yeah. Yeah, so ultra pulse CO2 laser, and then lifting the lesion off and using the laser to cut through. If it's for a subepithelial resection, I'll often use a microflap elevator and see if it elevates well, and I'll do it cold because a little less thermal damage. But other than that, yeah. For the office ablations, I'll use the KTP laser or now the blue laser. But in the OR, I really like the CO2 as a cutting tool. Thanks.
All right, next we'll bring Dr. O'Rourke back to the stage to discuss retrograde cricopharyngeal dysfunction. If you haven't seen patients with this in your office, they're coming for you. So we're excited to have this talk.
That was really sinister. They're coming for you. Okay, we're going to wrap this up by 9, so we'll just get right in. How many folks in the room have heard of RCPD? All right, how many people in the room have treated RCPD? Okay, great. All right, it's coming for you. Okay, so we're going to define RCPD, talk about the clinical symptoms, diagnostic approaches, and treatment. And I think this is a really interesting dichotomy in when we talked about CP dysfunction, and now we're going to talk about retrograde cricopharyngeal dysfunction. So we went over the anatomy. We know it's a striated muscle. Okay, so what is RCPD? It's the failure of the cricopharyngeal muscle to relax, so sounds really familiar with what we said before about CPD, right? CP dysfunction. And allow, however, the retrograde passage of air from the esophagus. So now we're talking about retrograde. It's the really just colloquially known as the inability to burp. Some people call this no burp syndrome. Some people call it abelchia. That seems to be our New Zealand and other European counterparts. Associated symptoms that people will come in with, besides the classic symptom of I can't burp, will be gurgling, abdominal bloating, excessive flatulence, and chest pressure or discomfort, particularly around mealtime. Less commonly, people will say that they have an inability to vomit or sometimes do air vomiting, almost like a croaking that will occur, nausea, hypersalivation, hiccups, social anxiety, especially if people have that croaking or gurgling and they're in class because it's younger folks and they're in college and they eat a meal and they go to class and now they're croaking or gurgling. Constipation and shortness of breath, I don't know. It's kind of like what else can be attributed to GERD or LPR. I think when you get lower down on the symptoms, so the ones to kind of focus on are the ones up on the top here. These are the most common ones that people kind of see. What is it not? A person who has dysphagia, a person who has GERD or LPR, or a person who has globus. That is not RCPD. So RCPD is the inability to belch and then may have some other symptoms with it. But if you have dysphagia, you're talking about something totally different. I'm going to show you some data that's under peer review right now, has not been published, coming out of the Medical University of South Carolina, in which we looked at all of our patients who had presented previously with abelchia. And the inability to burp at presentation was in all of the patients. I think the cohort was about 40 patients at this point, 36 with complete data. So this is a little bit ago data. And then you see that gurgling, abdominal bloating, avoiding carbonation. Most of them couldn't remember since childhood, so long-term not being able to belch. That was about, if you look at about 60% of patients. So this is long-term. It didn't just happen in the last few months. What's the pathophysiology of RCPD? We don't know. Hasn't been studied enough to know exactly what the pathophysiology. Why does the cricopharyngeus muscle open, have neural inhibition to be able to open during swallowing and not have any dysphagia, look normal on an esophagram, but not allow it to open when you have built up of intra-abdominal or intraesophageal pressure. It may be possibly related to some kind of the neural control that's controlling muscle relaxation during esophageal distension. So that interaction between brain gut. So an esophageal disorder where we're not getting proper feedback that then allows that inhibition of the cricopharyngeus. Did you know that when the UES opens during swallowing, the LES opens? So the LES does not open when the bolus gets to it. The lower esophageal sphincter opening is controlled by opening of the UES. And unless you have a disorder like achalasia, LES achalasia, or something like that, your LES will open when your UES opens. And so there is a very in-tune feedback. And remember we discussed in that one patient that had the stroke, the nucleus ambiguus is the central pattern generator for both the pharyngeal and the esophageal swallows. So there is this huge feedback loop, this really well-rehearsed timing that's occurring. So it could be that this is an esophageal disorder, not necessarily a cricopharyngeal disorder, but that's Ashley O'Rourke's interpretation of what this might be. It would, how we can figure that out, I don't know. I don't know if I really want to be known for our CPD research, but it's, I think it's a very interesting feedback. If you are interested in this, I think it would be great to kind of try to elucidate this. Interestingly enough, it tends to affect younger individuals. In this paper that you see below, it was the mean age was 26 years with a slightly higher rate of males. In our data, it was actually a little bit older population, but still a younger population than what we would consider the CPD or the cricopharyngeal dysfunction. And then we had more females than males who were presenting in our cohort. This is just to bring up a point too. These are our data. There is an ongoing study right now that's a prospective multi-center trial being led by Johns Hopkins. We are participating in it, and there's about 9 sites around the country that are prospectively collecting data on our RCPD patients, what they're presenting signs, collecting data, outcome measures as well. So that will be interesting when all of that is published too, to kind of bring together our knowledge. Because right now, if you look at RCPD literature, a lot of it comes out of just very few places, mainly centered in either the Midwest or the Northeast. And so we don't have a lot of data from other populations or from other institutions. So I think that's important. Not that the work that they're doing isn't good, but I think it's important to show that reproducibility and that it's generalizable to all of the patients that we are seeing in our day-to-day. Okay, so RCPD versus what we can call anterior grade cricopharyngeal dysfunction. So retrograde versus anterior grade CP dysfunction. I hope this doesn't catch on because I don't know. I'm used to just CPD. But if we look at the differences between the two, they're very important. Retrograde cricopharyngeal dysfunction it doesn't allow retrograde passage, whereas with cricopharyngeal dysfunction, you're going to have dysphagia because there's impaired anterior grade passage of the bolus. Inability to burp versus dysphagia and food sticking in the throat are the two main symptoms that we see. Cricopharyngeal fails to relax for retrograde passage, fails to relax for swallowing. Common symptoms are different. When we see anterior grade, we're going to see coughing while eating, choking, signs or symptoms of aspiration, regurgitation of food or liquid, that food sticking kind of thing, where we should not see dysphagia or those types of things when we have retrograde dysfunction. It's going to be very different, kind of what we see in those patient population. How do we diagnose this? Well, we're going to get a little bit into that. The diagnosis right now is a clinical history, and there's a big thought that maybe just the response to Botox. If you get better, then you have RCPD. And then I'll show you some screenshots from high-resolution pharyngeal manometry. And in anterior grade dysfunction, we just kind of talked about in the panel that there's all kinds of different things that we can do. The treatment for RCPD is Botox and cricopharyngeal myotomy in refractory cases. We'll talk about this in a little bit further. So how common is it that you're going to be seeing this? Look at this Reddit forum, just like Dr. Fink kind of alluded to. Look at how many members are in this. There are 36,000 members of the No Burp, It's Not Just You. So there's a lot of folks. If you get on this Reddit forum, you will start to get a ton of referrals. So maybe plant yourself there if you want this. But it's how a majority of my patients do come to me, is they come to me with their diagnosis. So they will come and they will know, I can't burp, haven't burped since childhood, can never remember burping, I have gurgling, I have chest pressure. They will regurgitate everything back to you, no pun intended, just from that kind of crowdsourcing and social media and what they've read. Doesn't mean they don't have it, but it means that you come to a patient that gives you each one. There's actually some coaching on some of these sites that say these things to make sure that your physician gives you 100 units of Botox versus 75 versus 50. So they come in with a preconceived notion of what they have, what their treatment's going to be, and even down to the Botox that they're going to get. So not that it's wrong, but it sometimes can be a difficult conversation if you have a different thought on what they might have. So it's primarily based on clinical diagnosis, based on history. There's controversy regarding what's the appropriate evaluation for this. And then at the root of this is response to Botox just both diagnostic and therapeutic. Like intervention makes the diagnosis. There's not many other diseases that we have that do that. Like, I'm just going to treat it and see it, and then if you do well with the treatment, then that's your diagnosis. And that's like a weird way of thinking about it, but that's what's been proposed for this. So on one side it says, yes, Botox response is diagnostic of RCPD, so there's no need for all this pre-op procedural, sorry for the typo, testing if classic symptoms are present. But then there's the opposite argument that says that relying solely on Botox response risks misdiagnosis and inappropriate treatment, and that really objective preoperative evaluation is really essential. So why do I think, this is completely my bias, but why do I think Botox response alone is not sufficient for diagnosing? Number one, the response is nonspecific. Number two, symptom overlap can be misleading. Number three, objective testing does add value. 4, there's risks of skipping evaluation. And 5, it's just best practice in patient care to evaluate prior to prescribing treatment. I'll talk about each of these. Botox relaxes the upper esophageal sphincter regardless of the cause. So that treatment is going to relax the sphincter. So you're going to get symptom improvement if you have a CP bar, if you have neurologic UES dysfunction, or if you have cricopharyngeal spasm. So they may not have RCPD, which theoretically has a cause that's like maybe esophageal distension doesn't result in the proper UES relaxation. So a positive response doesn't really mean definitively that you have this classic RCPD. I don't think we know enough to know that. In addition, the symptom overlap can be misleading. RCPD symptoms overlap with EOE, eosinophilic esophagitis, functional GI disorders, LPR and GERD, as well as esophageal motility disorders. And in our unpublished data that's under peer review, there was a significant over 50% overlap with GERD. So I think that clinical diagnosis based on symptoms only risks mislabeling patients. Objective testing also adds value. So you have a lot of options which can confirm or refine the diagnosis, can identify some coexisting abnormalities, but also provide a physiological baseline for somebody who may not respond, like what's your next step. If you skip the evaluation, inappropriate Botox use or escalation to therapy may be inappropriate for that patient. And potential harms are ineffective treatment, which is a harm to a patient. If you prescribe a treatment without a diagnosis that then they don't respond to, that's actually a form of harm. Okay, it's not terrible harm, but it is harm. They underwent a general anesthetic. So now for most individuals, there are some sites that do Botox for the cricopharyngeal muscle in the office. Usually they'll do it unilateral because of the risk of getting the PCA muscle. Many folks, myself included, and I'll show you why in a second, do it under general anesthesia. And then you're just delaying the correct diagnosis if this is a misdiagnosis. So I believe there's best practices in dysphagia care. Those related kind of dysphagia care is that evidence-based management supports a comprehensive evaluation, and that aligns with our standards in academic and multidisciplinary care, and then it promotes patient safety and long-term success. So that's my little soapbox for that. And we're going to skip this because it's not germane to here. So what else can we do to make the diagnosis besides just looking at their response to Botox. High-resolution manometry has actually been shown that if you give somebody a carbonated drink, and the amount of carbonation they gave these folks is crazy. It's 200 mLs of carbonated liquid that they gave these folks. But what happened is they developed a lot of intraesophageal pressure, and the UES just tightened. So instead of allowing them to burp, the upper esophageal sphincter, the red is higher pressures, whereas the green is lower pressure. So they had all of this pressure build up here in the esophagus, which should be blue, and the UES never opened. And so it can be that it demonstrates this pathognomonic sign of where you get these really elevated pressures that aren't released. And you don't see those in healthy individuals that you give the same carbonation challenge to. So this is a cool way to kind of diagnose this. It also gives us some ability to look back at some of those data. How do we treat RCPD? Botox is the first line treatment, and then we do surgical myotomy for refractory cases. I think if you're someone who says, look, I'm going to use Botox as my diagnostic and therapeutic evaluation RCPD, I would argue to you that's fine. Everybody has different practice patterns. It maybe isn't what I would do, but I'd say if you get to this part, then you really should be doing a comprehensive evaluation. If you're going to go to the next step, I have a person right now, I treat a fair number of RCPD patients. I have a patient right now who did not respond to RCPD. I didn't think she had RCPD, but again, the shared decision-making in that after some other things, we did a trial RCPD. She didn't get better with Botox. Her response is, I need more Botox. And my response is, you do not need this. We need to look at alternative diagnoses. And that's a very difficult conversation in somebody who is convinced that they have this disorder, but now didn't respond to what the first line treatment is. So do we go on to now even more invasive procedures in this situation? I think not. So if you get to here, have I done a myotomy for a patient with RCPD? Yes, I have. I've done that several times, but those were people who had the diagnosis based on other evaluations there. Also, behavioral interventions can be very helpful for patients. If you drink a soda and that gives you really bad RCPD, then maybe you avoid carbonated beverages, and that could be something to do. There's a wide range of Botox that people can give. Most of us use 75 units, maybe even up to 100, but 75 is kind of the general. That's the most common, even though there's a large range of dosing in the literature. Okay, this is what I'm going to leave you with because we've talked a lot about a lot of different things. This is my proposed RCPD evaluation algorithm. Again, under peer review, it's not, I think there's several things we can add. It's just starting to kind of say, how can we wrap our heads around this? What should I be doing at a minimum? And again, this is in your handout, but please remember this is not peer reviewed. This is our opinion out of our institution. So this is how we work this up. First of all, we do a detailed history and laryngoscopy. If dysphagia is present, we go down a different route. So if yes, dysphagia is present, they're getting a video fluoroscopy, EGD, consider pH impedance testing, et cetera, et cetera. We're going to look for some alternate cause for their symptoms. If dysphagia is not present, they have those classic symptoms, so the history is classic, they don't have dysphagia, then we're going to discuss the CP Botox procedure and get informed consent so they understand the risks and benefits. We do a pre-procedure esophagram. What I'm looking for are anatomic issues. I'm looking for a hernia. I'm looking to see, do they have spontaneous reflux? I'm just looking for other things that may go along that may be masking or even concomitant with their RCPD. Again, looking at esophageal function. If somebody has severe dysmotility, then I'm going to maybe get off that ramp and I'm going to go a different direction. So if their esophagram is unremarkable, then we're going to go to a CP Botox. If their esophagram is not unremarkable, then I'm going to maybe do some additional evaluation based on those findings. Maybe do an esophagoscopy, maybe do manometry, I don't know. But as long as this is unremarkable, we kind of go down this line where I then go to the OR. We're doing CP Botox. I do 75 units for most folks. We do esophagoscopy at the time of the CP injection, and I take biopsies. I'm looking for eosinophilic esophagitis. This is the age population for those folks that have it, and it can mimic RCPD. I have found 2 people with eosinophilic esophagitis that were classically RCPD. So this is a kind of like a don't miss diagnosis, pretty easy to do. Other things that I've seen on esophagoscopy, Class A, LA Class A, LA Class C esophagitis. So esophagitis from mild to significant, hernia, other things like that we see. I've seen people with furrows and other things that are like lymphocytic esophagitis was one time diagnosed. So there are some other things that you can see. Reflux esophagitis is often diagnosed as well. You saw that in a bunch of people in this paper when hopefully it comes out. You'll see that there's a significant number of people who have other issues. Then after this, we see they start burping exercises. This is something that's important. 2 weeks after they get their CP Botox, then they go on to teach themselves to burp, drink carbonation, burp. Google how do I teach myself to burp, comes up with all these videos. That's what we give them. And that's about it. So I'm going to leave you with that because we are just at time, and we will, and I'm welcome, I'll stay around if anybody has any extra questions or if there's anything that you would like to talk about. Thank you.
I have one announcement before we take a short break here. By the way, the break does end at 9:30, and we'll ring a bell to remind you guys. But Dr. Robbins asked me to invite all program directors and any faculty to attend the annual faculty development workshop that is this afternoon at 1:30. This year, Kim Lomas, who's from the AMA GME department, will present entrustable professional activities. EPAs are a crucial step in competency-based medical education and the direction that our graduate medical education is going in. If you're unfamiliar with these or want to learn more about them, she will be speaking at 1:30 in the camp room right down the hallway here. Enjoy a 30-minute break and be back here in 9:30 for the next section of our content.